Okay, hello everyone, good morning. We're going to go ahead and get started. We're running a little bit late as it is. So thank you for coming and welcome from the Center for Global Health and the Med School. I'd like to take this minute to say thank you to our center's team, especially Andy Yost and Kat Smith, who put a lot of work into this, organizing logistics. So just to get started on how the day is going to go, we'll have our keynote speaker first, a panel, a short break, another panel, and then lunch following, so hopefully you can stay for everything. I'm really excited about the array of global health experiences that we have represented today among our keynote speaker and our panelists. To just review a few, I won't go over too much because it's obviously in the bios, but one, our keynote will be talking a lot about building effective and sustainable partnerships and in-country capacity. He has years of experience in that. There will be talk about translating science into action for low-resource settings, bringing awareness to neglected tropical diseases through storytelling, reaching Native American populations through prevention and treatment, and advising in clinical policy and health economics with bilateral agencies. Many of our panelists have lived in the communities they've served for long periods of time, and one still does right now, and that person will be joining us remotely. And then at least one of our panelists learned to speak a language for her work, and that's Swahili, and perhaps others did too, so we'll hear about that hopefully. Now it is my great honor to introduce our keynote speaker, Dr. Corrado Concetta. You have his bio, so I won't read his bio. You can look at that. But I just wanted to say something that's not in his bio that I found out about him a little bit more. That was a couple weeks ago. I was attending a global health conference in New York where I met up with Corrado and a colleague from another university. And the colleague from the other university started talking behind Corrado's back after he walked away. And it lasted for a while. The other colleague was eager to tell me about a sticky situation that he was in with his American institution in Rwanda while Corrado was living there and working there. And he noted that the problem was coming from the American institution side rather than the Rwanda institution side. And he went on to say how Corrado used some really fantastic mediation skills and careful listening skills to help work him through that. And he was extremely grateful for that because it could have been, potentially damaging situation. He then continued on to describe Corrado with the following adjectives: as such a thoughtful and humble listener, highly respectful of different cultural contexts, one of the most even-keeled people he knows, extremely patient, and just simply kind. I can't think of better characteristics to describe someone to work in global health. And that all being said, I'm also very excited and happy and proud to share with you that Dr. Concetta is our next country director for the Botswana-UPenn partnership. That was just made official this week, so you're hearing it first. So please join me in welcoming Dr. Concetta to Penn officially as well as to the stage. Thank you.
Thank you. Thank you so much. Thank you. Well, thank you very much. That was a very lovely introduction. Thank you so much for being here. Happy Easter and happy Global Health Career Day. I'll be talking a little bit about my work in global health over the past 11 years. The title of the talk is Equity and Sustainability in Global Health Partnerships, and I'll talk about the 3 countries where I work the most, which are Rwanda, Sierra Leone, and Liberia. Because this is Global Health Career Day, I'll start talking about my path to global health, which was not linear, and for those of you interested in global health, yours is likely to be non-linear as well. I was born, it's just a part for the course, I guess. I was born in Genoa, Italy, which is a lovely medieval town. It's the birthplace also of Christopher Columbus and pesto sauce. I went to medical school there, and I got my MD, and then I thought I was going to be actually a scientist. I come from a family of like a bench scientists. So I got my PhD in immunology and did some research in immunology, which I really did not like. So I decided to do clinical medicine, and I decided I wanted to do it in the United States because I felt like the training was better. I did my residency in medicine in the Bronx, and I did my ID fellowship in St. Louis at Barnes-Jewish Medical Center. And I was there. I was really struck by the fact that I was seeing patients that had the same diseases of the patients that I had in Italy, but it was different. Like in Italy, I would see like these 90-year-old ladies that had diabetes that were coming in with like the daughter or the granddaughter, and they would remind you that you wanted to change the dose of the diabetes medication because you had told them in the previous visit. But when I was in the Bronx, when I was in St. Louis, I was seeing patients that had the same disease, but had every single complication and were 20, 30 years younger. They had diabetes, they were blind, didn't have legs, they were on dialysis, had end-stage heart disease. And I remember when I was in St. Louis, the first 2 weeks, I had 2 young women in their 20s who died of HIV/AIDS. And this was 2005. It was the time when the medications were already available. This was supposed to be a chronic disease. And this was one of the best teaching hospitals in the country. It made no sense. So I became really interested in social determinants of health. I became familiar with the work of Paul Farmer, read his books, and decided I wanted to work with him. And I reached out to him and to Joya Mukherjee, who's the Chief Medical Officer of Partners in Health. And I said, listen, I would love to work with you guys. And they said, great, why don't you go to the mountains of Lesotho to do community outreach for HIV/AIDS? Which I did during my ID fellowship for a couple of months. I absolutely loved it. I think they enjoyed me as well because they offered me a job in Rwanda, and the rest is history. I spent 4 years in Rwanda. I spent a year in Sierra Leone. Well, in Rwanda I met my lovely wife, so I also got married through Global Health, and spent a year in Sierra Leone during the Ebola epidemic, started working in Liberia, and now I'm here. So just keep that in mind, that things can happen quite serendipitously, and you just have to be open to the opportunities when they arise. You will be entering the field of global health at a very exciting but difficult time. If you look at the trajectory of global health, since the early days, it's still evolving. It started out as tropical medicine during the colonial era. It moved into international health at the end of the Cold War with Alma-Ata and selective primary care, and then it really became global health in the 90s and the early 2000s, driven by the HIV/AIDS epidemic and the rise of the MDGs and big donors like the Global Fund, PEPFAR, and the Gates Foundation. And now we're in a new phase where there's like this epidemiologic transition to NCDs. It's not that infectious diseases have gone away, but NCDs are becoming more prominent. We have now the Sustainable Development Goals, which is like really the North Star for development until 2030. An emphasis now on countries running their own health systems and maybe reducing development assistance. Maybe too soon for that, but we'll talk about it later. And then this notion of New World Health, where it's really not so much rich countries helping poor countries, but thinking about health on a global scale and how to make sure that everyone everywhere has access to high quality and comprehensive health services. And there's this notion that the health of individuals, it's tied to the health of the environment and is tied to the health of animals. So this notion of One Health or planetary health, right? So it is a very exciting time. Challenging because there's not a lot of money to go around, and we'll talk about that as well. So the SDGs, talked about it earlier, really the North Star for international development for the next 12 years. There's 17 of them. SDG 3 is global health. It's 16 targets for health, including building the health workforce, which is something that I've been working on quite a bit. But the ones that I'm really excited about are 16 and 17. 16 is about building effective, accountable, and inclusive institutions at all levels. And 17 is about global partnerships for sustainable development. And the way I interpret this, even through my work, is that if you have partner A and you have partner B, they're going to get together to pursue the SDGs. But through the partnership, they will also strengthen their own individual capacity to keep pursuing the SDGs once the partnership is over, and even establish additional partnerships to keep pursuing the SDGs. And it's this institutional capacity strengthening and ongoing partnerships that make the goals indeed sustainable. For all the talks about partnerships, there's not like a ton of evidence that shows that they're effective. I mean, we all believe in them, and we all know from our experience that partnerships are the key to success. But in terms of like data that shows that they work better than other models of international development, there's not a lot of it. This is a study from Globalization and Health that looked at other studies of partnerships, and these are the levels of evidence from 0 to 5. 5 is really the highest level of evidence. It's a systematic review, and there was very, very, very little data. The majority was level 0, level 1, which were expert opinions, advocacy pieces. And when you study partnerships, there's several things that you study, right? You study the individual partnerships, and within that partnership, you study the type of activities, the quality of the partnerships, like adherence to certain principles or best practices, and the degree to which the partnership actually achieves the goals that were set at the beginning. But you can also look at organizations that manage a portfolio of partnerships and the way partnerships strengthen health service delivery. These are some guiding principles that the Tropical Health and Education Trust put together. And again, they're not like validated, but all of us in the field will look at them and they make perfect sense, right? Partnerships need to be strategic, harmonized, aligned, effective, sustainable. All these are like critical words, part of the global health jargon: respectful, reciprocal, organized, accountable, responsible, flexible, committed to joint learning. This is the European Ester Alliance. These are like domains of goals by which they evaluate partnerships in global health. So they need to be relevant, efficient, effective. They need to have an impact, and they need to be sustainable. Again, like the word sustainable is recurrent. This is another framework to sort of look at partnerships. You look at the thematic focus that can be wide or can be narrow. And so a wide thematic focus is, for example, several diseases or several clinical specialties. A narrow thematic focus is just an HIV intervention. And then you look at the scale. It can be small, just 1 or 2 districts in a poor country, or it can be large, the whole country. And so I'll talk about some of the work that I've done related to these different domains. Starting with work in Rwanda, when I was working for Partners in Health, which is an NGO affiliated to Harvard Medical School and Brigham and Women's Hospital, and I was serving as the Director of Medical Education and Training in 3 health districts. So when Partners in Health went to Rwanda, this was 2005, the country was already recovering from the genocide, but had specific areas, specific districts that were really underserved, where the health systems was incredibly weak. And Partners in Health decided that the priority there had to be to take care of patients, that research and training would come afterwards, and would have to have a direct impact on the care that was being delivered. So this was like at the time the more traditional model of engagement of NGOs versus academic institutions, where NGOs really did health service delivery and academic institutions were doing training and research, but there wasn't like a lot of integration. The idea was really to bring this together, to have teaching health facilities in poor parts of the countries where the training and the research really directly affected the quality of the health services that were being delivered. So the training would be competency-based, not classroom teaching, but training health workers as they were seeing patients, and the research was really implementation research, like trying to figure out how to improve the delivery of health services. So what does it mean? It means that in 3 health districts, Partners in Health worked with the government. They took on a bunch of health facilities, whether district hospitals or centers that were dilapidated, didn't have enough staff, didn't have enough resources, equipment and supplies, and they improved all of these things. And then they integrated the existing staff with local staff recruited by PIH, but also with staff from the United States who was based in country. I like this picture because I think it talks more than 1,000 words. So here I am as a faculty at the Brigham and at Harvard, seeing patients with a Brigham resident in global health, but also training a local physician. There was something very powerful about this model, about the synergy. And as a result, we were able to leverage in these 3 health districts the resources and expertise available at Harvard and at the Brigham to launch a bunch of training programs in country in partnership with the Ministry of Health and with the university there. So we started a family medicine residency there. We started a CPD, a continuing professional development course in non-communicable diseases, a lot of training of nurses, including mentoring and enhanced supervision program for nurses in health centers that were doing primary care, and a lot of work in community health. It was all great. The problem was that it wasn't to scale, meaning that we were doing great work in 3 districts, but Rwanda is much bigger than that, has a lot of academic institutions and teaching hospitals that need to be supported. And so what we were doing in Rwanda needed to be scaled up nationally. And that's how the idea of the Human Resources for Health program with the Ministry of Health and support from the Clinton Foundation came about. And the basic idea here is that you have a consortium of US institutions, which is here. It's 22 of them that send the faculty to Rwanda at the medical school, at the nursing school, at the School of Public Health to train Rwandans. But the program is entirely managed and run by the Ministry of Health, and it's funded by PEPFAR and by the CDC. And if you look at the 3 main goals of the program, well, number 1 is to have a large, diverse, and competent health workforce. But number 2 and 3 are to also retain some of the Rwandans who are trained as faculty in the academic institutions and establish additional academic institutions with the U.S. additional academic partnerships with the U.S. academic institutions that outlast the duration of the HRH program. And that really speaks to the institutional capacity strengthening and the sustainability for the medical school and the nursing school in Rwanda. The U.S. academic institutions are organized in a consortium to coordinate their contributions. So some U.S. institutions just focus on training doctors, some just focus on training nurses, some just focus on health management, and it's really to avoid any gaps and overlaps, so it's all very highly coordinated. And in terms of the scale, this is not just training like 20 nurses here, 15 doctors there. This is like a national plan. So we're talking about thousands and thousands of health workers, and this is not just a continuing professional development, like a week of training for nurses who already work in the health system. This is really going at the level of the academic institutions. It's about higher education. It's about the medical school, residency programs, PhDs for nurses, PhDs for implementers. This is the governance structure, and this is just to emphasize that it's really driven by the Ministry of Health and by the Ministry of Education. The Ministry of Health decides how many health professionals they're going to need in the health system. The Ministry of Education is aware of the priorities of the academic institutions. There's a steering committee that determines year after year how many US faculty are going to need. And then they tell the US academic institutions who recruit and deploy them. Funding, this is also very important, doesn't go from the US government and the Global Fund to the academic institutions. It goes to the Ministry of Health, who then gives it to the academic institution. So again, it's all designed to keep control in country. And then one last thing, the academic institutions keep very little overhead. The idea of overhead is that when you get a grant, some money is needed to keep the lights on, you know, to keep the infrastructure in place. And the US institutions have agreed to use very little of development money for that, because they understand that the priority there is to send the money in country. These are all the training programs supported by the HRH program. So there's, it's 22 of them, 13 of which did not exist before. And we've been quite successful. This is the number of people that we've trained across cadres of health professionals. So, for example, for physicians, these were the original targets for the HRH program. These were how many people were trained in the 7 years before the HRH program, and this is how many we're training year after year. These are cumulative numbers. This is for nurses, this is for doctors, for nurses, for oral health professionals, and for health managers. In some cases, we're almost there, but maybe a little below the targets. In some cases, we went above. the way it works is that you have physicians who are, you have faculty who are in country, and they see patients, and they mentor and supervise residents, and they twin with local faculty. And we've been sending quite a lot in the early years. Now the number is going down because Rwanda is recruiting faculty. So there's like this notion of sustainability built in. And then when we, this is a busy slide, but the point here is that when we evaluate the HRH program, we don't just look at how many people we've trained, but we look at all the additional benefits, the additional partnerships and collaboration that we were talking about. So small grants to get local faculty and local health professionals to go abroad to conferences or even come to the United States to pursue some more training. A lot of research projects, some of them funded with additional grants. And I think it's very important to document these things as well, because it really gives the idea of like the way in which partnerships, when they are well structured, they affect a whole array of domains. And then the interesting thing is that I had to make the case to 7 Harvard affiliated academic institutions, the medical school, the dental school, and 5 teaching hospitals, that this was good for them as well. And interestingly enough, I used the same metrics that we were using to evaluate the HRH program in Rwanda. I made the case, this is good for trainees here who want to do global health, because they'll have opportunities to do that. This is good for our faculty, because they'll get their feet wet in global health, and they may develop a career in it. And we're going to get like more money. We're going to establish additional partnerships and collaboration. This is just the foot in the door. And so what does it mean? So these are the number of like Harvard trainees across the different institutions that participated in global health activities related to Rwanda because of the HRH program. These are the faculty that we sent. The cool thing was that a lot of departments didn't have like a lot of global health experience, like psychiatry or radiology or pathology, and this was like an opportunity to create that avenue for people in these specialties. We looked at papers that faculty from Harvard and students from Harvard published with Rwandans, quite a bit, and then we even looked at money that faculty and students who went to Rwanda were able to raise independently of the HRH program. Because people are smart, they come with ideas, they say, oh, it would be nice to study this, or we should develop this intervention to take care of this disease. They raise money, and this is the return of investment. Now, some of this money stayed in Rwanda, some of this money went to other countries, but the point was that the people who got the money needed their experience in Rwanda to get it. Sierra Leone was very different. So Sierra Leone was during the Ebola epidemic, and at the time, PIH had never worked in Sierra Leone, like ever. And this was the middle of the epidemic, and Sierra Leone at the time was the epicenter of the epidemic, and the districts where we worked were at the epicenter of the epidemic in Sierra Leone. Like Poloco district had the highest transmission rate ever documented for Ebola. It was 200 cases, new cases per week when we got there in the first place. And again, it was a skeleton team that started working in Sierra Leone in the middle of the epidemic. We were, of course, building our team as we went along, but we needed to decide how are we going to be helpful? And how can we scale up as fast as possible? So we made a few strategic decisions. The first one was that, again, we were going to partner with the government. We were not going to wait to have all the resources and expertise and infrastructure to run our own Ebola treatment units, because that would have taken months, and the epidemic was out of control then. We were going to work in Ebola treatment units run by the government, even though they were not as safe or as controlled as the ones that we might be able to set up ourselves. We thought it was practical, but it was also the moral thing to do. Like, we just had to do it. That was the first decision. And so this is a school, actually, that was being turned into an Ebola treatment unit by the government, and we joined the effort. We helped with infrastructure, with equipment, and then we supplemented the staff that the government had with our own staff, both expatriates and locals that we recruited. The second decision was that we wouldn't be too picky with what we did. So this is the architecture of an Ebola response, right? It was very complicated. It was run by the Ministry of Health and by the military with support from the World Health Organization and the United Nations. There was a headquarters in the capital, and then each district had a smaller governing unit. And then there was a bunch of like NGOs and foreign governments and the WHO, United Agency, that were actually doing stuff, either treating patients or doing community outreach efforts. And then there are donors as well. So it was very complicated. Each partner had like their own expertise, their own agenda, and we thought that the way to help, especially because we were coming a little late, was just be nimble and do what was needed. Just figure out a way to do it. One time we would treat patients, one time we would do community outreach. But our job was really to adapt ourselves based on what the needs were in the different parts of the country where we were working. The other thing is that we wanted to do a little bit of everything. So you can have a public health approach where your priority is just to stop transmission of the disease, or you can have a clinical approach where your priority is just to treat patients. And we wanted to, again, we felt like we needed to find that sweet spot where we did enough of everything to have the impact that we wanted to have. And that meant working at the different levels of the health system, right? So working in the community, working in smaller Ebola treatment units that were like closer to the community, and working in big isolation units that were in the largest cities. And the reason why this was important is that this is really a delivery chain. If you don't provide good treatments in the Ebola treatment unit, it's just a place where people go to die, your community outreach efforts, your ability to identify people with Ebola and isolate them before they infect other people are doomed, because why would they go to a place just to die? They want to go to a place where they have at least a shot at getting better. And so you really needed to act at all the levels of the health system. With this approach, we were able to scale up fairly quickly. So in 3 months, we were able to work in 4 districts, in 18 health facilities, and really scale up the number of patients that we were seeing. We ended up seeing over almost 2,000 patients by the time the epidemic was over. And in the Ebola treatment units, we really tried to push improved quality of care. It was like a phased approach, again, because we didn't have a lot of capacity and personnel to do it. But like every couple of weeks, we try to make the treatment protocol a little more complex, give antibiotics, give IV fluids. Because we wanted to see the mortality rate. We wanted to see patients with Ebola not die at an 80% rate, but do better. And we were like partially successful. We were able to go down from 80% to 49%. We did a lot of community outreach efforts. So again, the problem with Ebola is that it's very easily transmissible within family, right? It's the caregiver disease. You have a family member who's sick, you take care of them, you get sick yourself. So it's very important to identify patients who have early symptoms of Ebola and isolate them before they infect other people, and then family members who are exposed need to be quarantined, and then you just need to educate the general population about symptoms so that they do the right thing when they have someone who has symptoms in their community. And we use a network of 800 community health workers and 800 Ebola survivors to do that. And so we did quite a bit of community outreach efforts, like 1.1 million home visits, 357 individuals who had symptoms of Ebola we were able to refer to our Ebola treatment units. We did a lot of just general education on Ebola. Okay, the last partnership I'll talk about is the one that we currently have in Liberia. Again, Liberia was affected heavily by Ebola, and now they're trying to rebuild their health system. And they have a program there that's very similar to the HH program in Rwanda. It's called the Health Workforce Program. It's funded by the World Bank and by the Global Fund. It's approximately $130 million. And there's a consortium of US academic institutions that are sending faculty there. As the Brigham, we got another grant from the US government. It's a smaller grant, it's about $10 million. But the whole idea is that we needed to design our activities in a way that was very synergistic and complementary with everything that was already happening. So in the grant, we have Yale and New York universities that are also part of the Health Workforce Program. We're bringing in Partners in Health, who is already in Rwanda, but not part of the Health Workforce Program. And I guess the point of this slide is that it's really taking a lot of time, but it's the right thing to do to talk to all the different partners, primarily also with the Ministry of Health, to tailor every single activity that we do with what other people are doing, and if they change what they're doing, to change what we do as well. This is another way to look at it, where you sort of look at all the different types of health professionals that need to be trained and all the different set of activities that are needed and who pays for what. And again, it's this sort of like a very sometimes frustrating but necessary dance, like trying to figure out who's doing what and where you fit in. And the point I want to make here is that there's a bit of a ripple effect, because you know, the World Bank might decide, okay, this year we'll pay for this, but next year we won't. And that has an effect on us, because if something that they were paying for, after a while they don't pay for anymore, that's a gap, and we may have to change what we do so that the Minister of Health has their needs met. All right, so I've given some examples, and now we can take a step back and talk a little more in theory. When we talk about equity and sustainability, again, which we tried to enact in the partnership that I described, I think we all agree that they're important, but Steven Pinker would call them meta-concepts. We probably all mean something slightly different, and I think that's part of the problem, is that we don't have like necessarily a very clear definition of what they are and how we measure them. So let's say that you have two partners, right? And what I have here is sort of a hierarchy of business needs. It basically tells you how strong an institution or an organization is. And the two partners are at different levels in terms of resources and expertise. Not talent, but resources and expertise. What is an equitable partnership? Like, is it fair? Is it equitable if at the end of the partnership the benefits are equal between the partners? Or should the partner who has the greater needs and the most urgent needs see greater benefits? Should the partner that has that is better off have any benefit at all? Should they give away stuff? And you know, this is not necessarily an academic question. Of course, if we're talking about academic institutions, there needs to be like a return of investment. Equitable, but there needs to be a return of investment. But if you're talking about an NGO that wants to work itself out of a job, or a foundation, maybe the business model is actually just to give away stuff. And those are incredibly uncomfortable conversations, but I think it's really important to have them. Like, you really have to get in there with your partners in country and like really like lay it out. And then the other important point is that what does really sustainability means? At what point is something that you start doing together sustainable in and of itself? And let's say, for example, if this partner walks away from a partnership and the other partner has only the ability to keep things going as they are, but not the ability to build on those things and keep growing, is that really sustainable? Because I think it's in human nature always wanting to achieve more. So maybe what's sustainable is leave the other partner with the ability to build on what you've done together, not just stick with it. So it would be nice to have very specific metrics for equity and sustainability that tells us where each partner is at as the partnership evolves. And when you talk about these metrics, you can think about the more technical domains, the ability to treat patients, to do training, to do research, but also the non-technical domains, like the infrastructure that allows people who have the technical expertise to function. So governance, policy making, management, administration, money, the ability to find money, all the information technology and the infrastructure, equipment, and supply. Last slide. This is all great, this is all exciting. The problem is that money for global health is going down. I mean, governments in country are spending more and more money, but even though the Sustainable Development Goals are very ambitious and expensive, International donors, especially the U.S. government, have plateaued, and if anything, funding is going down a little bit. So we're going to need to find other money to get this going. All right, so if we wanted to summarize all of this, effective institutions and global partnerships are critical for the sustainability of the SDGs. The evidence for the effectiveness of global health partnerships is thin, even though we all know and believe that they are very important. How we define effectiveness and implement best practices may vary depending on the type of partnership and the circumstances. It's important to define what we mean by equity and by sustainability and to develop metrics that tells us if they're being achieved or implemented. When you think about metrics, you look both at technical and non-technical domains, and global health financing, especially development assistance for health, is a challenge, and we need to think creatively about funding extra money. Now, what's the implication for you guys who are interested in pursuing a career in global health? So, well, this is my pearls of wisdom, I guess. The first one is that you will enter the field at a time that is both exciting and difficult. That within the health sector, you can engage in global health as a clinician, doctor, nurse, pharmacist, researcher, educator, social worker, manager, public health specialist, you name it, you can do it. You can even engage from a sector outside of health. I think we have a veterinarian here, so perfect example. From time to time, you will find yourself playing all of these roles, sometimes at the same time. Start small, think big. Start from patients, because there's nothing more grounding than starting with patients, trying to treat them in a system that maybe doesn't support you the best way, and then you move your way back to the health system and to the policy, because then what you do at a higher level will be informed by the experience of trying to treat patients where you don't have resources, when you don't have what you need to do it properly. Ask yourself the hard questions. Is the intervention effective? Is it enough, or should I do more? You know, sometimes the expectations are not high enough in global health. Is it equitable? How can I sustain what I have achieved? This to me is a very important point. Global health is also local health. PIH sent me to Lesotho, and then I fell in love with working abroad, but I would have been perfectly content working here. There's a lot of health disparities. Think about West Philadelphia, predominantly African-American communities, or Appalachia, poor rural white communities. Just think about global health also locally. Know that you will have to be creative, entrepreneurial, chart your own path, but it's getting better. There's more and more support for a career in global health, and you have role models and mentors now. And then global health is supposed to be hard. So if you find it hard, it means you're doing it right. Thank you very much.
Started. Good morning, everyone. Hello. Thank you again so much for joining us for our third annual Career Pathways event. My name is Andy Yost. I am the training administrator for the Center for Global Health, which means I work with medical trainees from med students, MPH students, to residents and fellows. I help these trainees coordinate clinical and research experiences abroad, sometimes in the summer, sometimes throughout the year. But as part of this role, inevitably, career paths is a subject that comes up. And I'm very pleased to be moderating this panel on local and global public health practice. I'd like to give a brief introduction to our first speaker, Hannah Bergbauer. Hannah is a nurse midwifery and women's health nurse practitioner student here at Penn. She has previously worked as a nurse educator in Tanzania from 2014 through 16 with the Global Health Service Partnership, which is a partnership between the Peace Corps, Seed Global Health, and PEPFAR. And following her time in Tanzania, Hannah worked as a nurse mentor in Malawi with Partners in Health. So please join me in welcoming Hannah Bergbauer.
Good morning. I always feel so formal when you stand up here like, okay. Thank you for that introduction. I am a nurse, and I'm Happy to see a few nurses here today. And I want to give full disclosure for my pictures. Everyone that I have in photos has given me permission to use them. So, who am I and why am I here? So, I'm a nurse, and I left with the Global Health Service Partnership in 2014. As Andy mentioned, now I'm here back at school at Penn. After doing a few years overseas, I realized that I actually needed to be a nurse midwife and a women's health nurse practitioner. So I'll talk more about that as we continue in the presentation. And then I'm also an associate scholar for the Center for Global Health. I like to give that plug for the Center for Global Health always. So I'll start out talking about my pathway a little bit. One of the things that I've encountered with nurses who want to do global health is sort of, it seems like there might be a more streamlined, I mean, everyone goes in different directions, right? It's not a straight path, but for people going into medicine, it seems like there's a lot more folks doing global health, and there might be more people to talk to about how to get into it. And so a lot of times it seems like nurses are sort of curious about what the best ways to go are. And I don't know that there's necessarily a best way, but this was sort of the way that I ended up in global health. I got my bachelor's of science in nursing, and then I went straight into an MPH program. I thought that I was just going to talk about the social determinants of health in the U.S. for as long as anybody would listen, because I had started working at in the emergency department setting at academic institutions at the same time, so I was seeing a lot of those social determinants actually at play. And then I realized, as I had started a Doctor of Nursing practice program, that I hated what I was studying, and that if I could be anywhere or do anything, I would be on the other side of the world. So I literally Googled global health nursing, and somehow the Global Health Service Partnership came up, and I applied, and then left a year later. And so I was there from 2014 to 2016, and then I was in Malawi for a little while with Partners in Health, and then I came back to the United States, and I moved here to Philadelphia last May to become a midwife. So what is the Global Health Service Partnership? So this is like a very formal version of what it is. The Global Health Service Partnership is a joint initiative with the Peace Corps, the U.S. President's Emergency Plan for AIDS Relief, and Seed Global Health that partners with countries to help them overcome critical shortages of health providers and build strong, sustainable health systems. So you've heard Corrado speak a little bit about, well, a lot actually, and he's very, well-versed in this. But it's some of the same concepts in terms of education and sustainability and building capacity within those academic institutions. And I was actually on the side of it where I was one of the participants at the institution partnering with faculty and teaching students. So what does all that really mean? Basically, what I just said is that nurses and physicians have been sent to 5 countries now throughout sub-Saharan Africa to partner with academic institutions and teach students. And currently the project is in Tanzania, Malawi, Uganda, Sierra Leone, and Liberia. So I'm talking to a group of people who are interested in global health, but I always put this slide in because people will say to me, well, people are dying. Why aren't you just going and providing direct care? So it is necessary for us to provide, care in places where it's needed, but also the education piece can be summarized a little more clearly when we look at these numbers. So yes, 70% of the global new HIV infections will happen in sub-Saharan Africa. There's a critical shortage of healthcare providers of about 7.2 million. 11 countries in sub-Saharan Africa do not have medical schools or nursing schools. And I always put the 25 to 30 babies and 3 to 4 mothers on there, which most people are like, what does that mean? That's specific to the facility that I was in for 2 years. That was on average per week the number of babies and mothers that we would see that didn't make it back home. So education builds capacity and a health workforce that can be sustained. So my role, basically what I was doing as a nurse educator was going in and partnering with the faculty who were my Tanzanian colleagues and teaching in the academic setting as well as the clinical setting. So I would teach some days during the week or be in the clinical setting some days during the week. I didn't have formal academic teaching experience. I just had clinical teaching experience prior. And I think in some ways it was good for me that I didn't know what it was like to teach in the U.S. because it was so different that I'm not sure how easy it would have been to adapt. So for example, the classrooms that I taught in had about 250 nursing students at a time. None of the students had textbooks. Most didn't have access to computers. The information that they were going to learn was going to be presented to them on the PowerPoint slide. So basically they would write everything down that they could, and then the students who had access to computers, we could give them copies of the PowerPoint. So it was very different. And then those 250 students and I would go to the clinical setting and be dispersed over about 18 wards. So it would be me and 250 students, and I was supposed to teach all of them, right? So that's a very different situation than what we see here in the United States. And I'll talk a little bit more about this student-led training team concept. Most people have probably heard of this idea of training of trainers, and sometimes we have to get a little bit creative with how that sort of looks. So as I had spent, several months in the wards, I realized that there was so much more that I didn't know than I actually knew. So for example, we kept resuscitating patients. So my first year I did things very differently than I did my second year. Like the first year, I was really worried about saving everyone, and my students were on that journey with me. And it didn't work because there were too many sick people, and we didn't have the capacity to handle that. And also, I would notice that we would leave after resuscitating patients, and then those patients would end up dying. And the next, after months of doing this, I finally was like, okay, this isn't working. So I've got to start having chai with my fellow nurses and figure out what's going on here. So basically every day I stopped pushing in it that same way, and we started having conversations. And it was 4 weeks later, I remember it very clearly, we had chai, and then one of the nurses, it was on the evening shift, and she said, can we talk for a second? And so, well, this was all in Swahili, because I can speak Swahili now. And so we go to the back of the ward, and we're just talking, and she's like, I saw you hang that bag of IV fluids. I don't actually hang fluids. And I was like, oh, here's the answer, because I've found all these leftover antibiotics and all of these leftover fluids in the drawer, and I'm like, why are these not being given? And so she said, well, I need you to show me how to prime the tubing. And keep in mind, there's no IV pumps. This is not complicated tubing, but no one had ever showed her how to prime the tubing, and there were 4 other nurses who worked between the evening and night shift that their colleagues from day shift, they didn't feel safe asking because they felt like they would be judged for not knowing that. And so I realized that there was a lot more that I didn't know than I did know, because I had never considered that the reason they weren't giving these antibiotics was because they didn't know how to prime the tubing. And so I had a conversation with my students about this, and we talked about all of the things that they felt like they needed to learn, that they felt like they weren't getting an opportunity to do, and basically we were able to come up with 10 champion students to form as our training team, and then they gained expertise in basic skills, and then we divided them up into training other groups. So I would have upper level students then monitoring under the freshman and sophomore nursing students, or diploma level students. So these are pictures of my students teaching the other students, because it was just impossible for me to be able to teach at the quality that they actually needed. So the value of the skills that I learned, actually through being there, was that we may wear a clinical hat, but public health can never be separate from any of the work that we do. So even if you don't have a master's in public health, you're going to be engaging in public health if you do any sort of clinical work in low resource or settings where people have lower socioeconomic statuses. I feel that my experience in the emergency department for several years before leaving was really crucial, because I was going to be working in skill providing direct skill translational settings. So I think that getting comfortable with the basic skills is really important. And then you spend time learning about best practices and engaging in this work. So being in these settings and having these conversations, even if it is a Saturday, is really important, and hearing about what other people have learned, because you can take those lessons and then it makes it easier on you. And always ask questions and learn before making any suggestions. So I don't know if any of you have heard that story about the elephants and the tomatoes, right? So there's these foreigners that come in and they see this field and they tell all these people in this low resource setting, like, oh, you need to plant all the tomatoes there. There's this field, and they let them do it, right? 2 months later, the tomato plants are like, they've created tomatoes. And then what happens? The elephants run through and crush it. And the local people are laughing because they're like, we knew that the elephants came through. That's why we don't use that field, right? So you have to learn these things by actually engaging with the community. So why did I come back to school? So for me, I realized that maternal child health was really important, and that most of my colleagues were already in a position where they had to practice way outside of their skill set or their scope of practice, and that I wanted to be able to engage in a different way also. So I feel like this is going to help me in continuing forward, in the maternal child health realm. And then I also like to mention that the work that we do is very interdisciplinary. So, I've found since I've been back that some of my greatest allies and best friends are people from different disciplines, whether it be public health or medicine, infectious disease. Even we're talking about this One Health approach where we have to engage everyone, so researchers, veterinarians. And then, we actually there's a very hierarchical form in terms of healthcare in Tanzania, and nurses definitely are not supposed to question physicians or advanced medical officers or that sort of thing. And we kind of re-engaged with that in a different way when we realized that my nursing students actually knew how to do a physical assessment and many of the medical students didn't. And so then after I had become friends with many of the folks in the medical school, they decided that some of the nursing students could actually come and teach the medical students how to do physical assessments. And that didn't change the entire culture of the system. It didn't change everything forever, but it did change the dynamic between those cohorts. And then I just believe that interdisciplinary partnerships are the pathway for success. And the most important message that I would have in terms of working with, people in global health is that we need to look to the people who know their home best. So a lot of times I would have ideas about different things that we should do and different things that were going to change everything, and it turned out that none of those things ever worked, but what did work was the ideas that my students or my fellow nurses or physician colleagues at the hospital had, and it was always important to engage with them first. And these are just some people who became my friends over the time, that actually taught me a lot about what it meant to be Tanzanian and living in that setting. And then building capacity. So I think that through my experience, this became something that's really important to me, because I realized that my students had the solutions to everything that they saw as a problem, and what I had was a set of skills that I had been taught in a really well-resourced setting. And so I had the opportunity to share those skills with them, but they had everything that they needed to solve their own problems. And then I just love this quote by Nelson Mandela. So education is the most powerful weapon which you can use to change the world. And these students, they actually graduated, the cohort that I spent a lot of time with, where the champions were, they graduated in November, so they're now all doing a nursing internship. And they've actually, after I left, they trained another cohort of champions to be the trainers, who have continued training within different schools and within their own school to ensure that, the quality of skills improves. So with that, asante sana. And then maswali means questions, but I think we'll get to that a little bit.
Thank you so much, Hannah. Our next speaker, Benjamin Johnson, is a first-year medical student here at the Perelman School of Medicine. Before med school, Benjamin was a clinical policy advisor with the State Department, and then a health economist with the Centers for Disease Control and Prevention, focusing on PEPFAR-supported HIV treatment and prevention in more than a dozen countries. Please help me in welcoming Benjamin.
Thank you so much. Good morning, everyone. As Andy mentioned, my name is Ben. I'm a first-year med student here at Penn. And before that, I spent 5 years working with PEPFAR. So my job with PEPFAR was to provide technical assistance to PEPFAR-supported HIV treatment and prevention programs. I worked in a lot of different countries, but mostly in Lesotho, Namibia, Uganda, Ethiopia, Kenya, Cameroon, Nigeria, and Haiti. And although I was based in Washington, Atlanta, I spent about 30 to 40% of my time traveling around to these different countries. And before I begin, I want to start by stating the obvious, which is that I don't have nearly as many letters after my last name as most of the other speakers here today. So there's a lot that I can't talk about, but what I can share is why PEPFAR is such a great place to work, what it's like to be a young professional working in global health, and how you can get your foot in the door if you're interested in working on global health programs for the U.S. government. So first off, PEPFAR has come up several times today, but I want to take a minute and just explain what the program is. So the U.S. President's Emergency Plan for AIDS Relief was started in 2003, and it's the United States government's flagship initiative to combat HIV globally. It works in 63 countries around the world, and in terms of funding, this is a very large program. Each year, PEPFAR gets an annual bilateral budget of $5.2 billion, and another billion goes directly to the Global Fund. So this is a lot of money, which is unusual in global health. And in fact, PEPFAR makes up over 60% of the total United States global health budget. That's a lot of money, but the program's impact has been tremendous. So in 2003, when PEPFAR was launched, there were only 50,000 people receiving antiretroviral therapy in all of sub-Saharan Africa. And there were many top officials in the United States who, unforgivably in my view, said that it wasn't possible to effectively run HIV treatment programs in Africa. Today, PEPFAR supports life-saving antiretroviral therapy for over 13 million people, and many PEPFAR countries have actually achieved viral suppression rates that are even higher than what we have here in the United States. So it's really changed the way that the United States thinks about global health, and it's also changed the nature of the HIV epidemic. So for all of these reasons, PEPFAR is really a humbling and inspiring place to work, and I recommend it to everyone here. That being said, you keep hearing PEPFAR, PEPFAR, PEPFAR. There's actually no such thing as PEPFAR as an organization. So organizationally, it's a bit complicated, since PEPFAR is made up of several different government agencies and hundreds of different implementing partners. So at the highest level, PEPFAR is led by the U.S. Global AIDS Coordinator, which right now is Ambassador Deborah Birx, who's a physician. Her office at the State Department is responsible for coordinating efforts across countries, setting the overall direction of the program, and also deciding country budgets. So the Office of the Global AIDS Coordinator, or OGAC, has about 120 staff. It's based in Washington, D.C., out of the State Department, and it consists of MDs, nurses, PhD epidemiologists, foreign service officers, civil servants. It's a very diverse group of people. And this is where I first started working for PEPFAR back in 2011. So while OGAC is responsible for setting PEPFAR's overall priorities, the actual implementation is divided up across several different government agencies. So CDC and USAID account for 85 to 90% of the total PEPFAR budget and implementation, but Peace Corps, the Department of Defense, and other HHS agencies and other government agencies also play an important role. So the fact that PEPFAR is actually made up of several different agencies working on the same program from slightly different perspectives is really an interesting opportunity from a career standpoint, since it's quite common for PEPFAR staff to move back and forth across different agencies, just like I did when I moved from State Department to CDC. And some people spend their entire careers with just one agency, but the interagency nature of PEPFAR means that there are a lot more opportunities for advancement, especially when you're just starting your career in global health. So in addition to being interagency, PEPFAR also has a geographic hierarchy. So at the headquarters level, you have agency leadership. These are people who are mostly based in Washington, D.C. and Atlanta in the United States. And then you also have technical experts based at this level who support several different countries so that they can share knowledge across those countries and set policies. Then, more locally, each PEPFAR country also has an interagency country team that's responsible for running PEPFAR in a given country. These teams are often based out of the U.S. embassies, and in addition to American staff, they also include locally employed staff who are citizens of the host country, and they are the ones who really, really know the program well. And then finally, PEPFAR funds are distributed to implementing partners, which are the non-USG organizations that actually run the program. And a prime example is the Botswana-UPenn partnership, which has been receiving PEPFAR funds for over a decade. So from a career standpoint, this geographic distribution is really a great feature of PEPFAR because it means if you're working within the organization, then you can move back and forth between headquarters and field, and to a lesser extent between the U.S. government and implementing partners. So it opens up a lot of opportunities, regardless of whether you want to be based in the U.S. Or based in the field, whether you want to travel a lot or not travel at all. So now I'm going to talk a little bit about my PEPFAR experience, since I think that my progression from intern to clinical policy advisor to health economist, and then eventually to med student, shows some of the strategies that you can use when you're first starting out in global health. So the fall of my senior year in college, I started interning for the Office of Global AIDS Coordinator in Washington at the State Department. And at that point, I really didn't have much global health experience, but I did have 3 skills that came in handy. First, I had previous experience in politics, which is important for a government agency that needs Congress to approve $5 billion in funding every year. Second, I understood the global context of the program because I had studied international affairs. And third, I was really good at crunching numbers because I'd worked at a political polling firm before. Pro tip, if you know how to use Excel well and can make even half-decent graphs, you will go very, very far in global health. So spend a lot of time learning how to do that. So because I knew how to analyze and present data, and I also knew the audiences, both domestically and internationally, that PEPFAR was trying to target with those messages, I quickly became the go-to number cruncher in my office. And so this was the first important career lesson that I learned working with PEPFAR. While there's definitely a need for people who have very specific and advanced technical skills, there's also a need for people who can work across fields and across subject matters. And this is especially important when you're just starting out in a field and building your experience. While I didn't have the same detailed technical skills that a lot of my physician and nurse colleagues had, my ability to integrate domestic politics, international affairs, and data analysis meant that I was able to play a very useful role. So after my internship ended, I was hired by OGAC as a policy support officer while I finished up my degree. And the more I learned about PEPFAR, the more I realized that in a program that has a fixed budget that's constantly pushing to reach more people, the key question that everyone always asks is, how much does it cost? How much does it cost to put someone new on treatment? How much does it cost to prevent the mother-to-child transmission of HIV? And this is a very difficult question to answer, and there often aren't good data on this. But I noticed that other than some very senior people in my office who were also very busy people who had a lot of other things to do, there wasn't really anyone in my office who understood both economics and clinical policy well enough to bridge these 2 areas and answer those questions. So at this point, I'd been working on the clinical team for several months, and I also had studied a lot of econ in college. So I decided that this would be my role. And over the next 4 months, I taught myself everything I could about health economics and cost modeling. And I built a number of different models that could project the cost of different PEPFAR services, like putting people on treatment or preventing mother-to-child transmission of HIV. And so before long, since I was the only one in the office who was working on this, I was creating cost projections not just for my office at the State Department, but I was also making projections for foreign governments that came to PEPFAR for assistance, as well as presenting my models at international workshops so that people could take these models, bring them back to their own countries, and use them to create estimates for their national programs. So this is another really important career lesson that I learned. If you want to advance in your organization quickly, identify an unmet need or a niche that interests you and figure out how to fill that role. For me, that niche was the overlap between clinical policy and health economics. And because I stepped into a role that no one else was able to fill or had the time to fill, I was given a lot of responsibilities that ordinarily wouldn't have been given to someone with just a bachelor's degree who was a few months out of college. So not long after I graduated, I was then promoted to clinical policy advisor. And at this point, my responsibilities included working with country teams in Ethiopia, Kenya, Cameroon, and Nigeria to collect cost data and use it to implement more effective programs, because PEPFAR's budget has been fixed for the past several years. And since I started in 2011, we've gone from having 3 million people on treatment globally to 13 million people on treatment now, all with a flat budget. And so what that means is we constantly have to figure out, how do we become more efficient? How do we identify ways that we can save money and then put that right back into putting another 1 million, 2 million, 3 million people on treatment? So I also helped build user-friendly tools that allowed other PEPFAR staff to use data for evidence-based decision-making. So again, Excel, if you can get good at Excel, it's really, really handy. And I also created both cost and epidemiological impact projections for PEPFAR's $5 billion annual budget request. So at this point, I was traveling internationally about once a month. I was working for a program that I deeply believed in. I thought that I had found my dream job. But what I realized was that without an advanced degree, there was only so far that I would be able to go in global health. And almost all the senior people in my office were MDs or PhDs. And I also increasingly found that the favorite parts of my job were the parts that brought me closest to patients, particularly when I had the chance to go out and do site visits at some of the clinics that PEPFAR supports, and I got to see the patient-doctor interaction and relationship firsthand. So for a variety of reasons, I decided that I wanted to be a doctor and that that was the best way that I can make an impact in the field of global health. Only problem was I hadn't taken any science classes in college. So slight setback. So I went back to school, did a post-bac, and then after my post-bac was over, I returned to PEPFAR for 2 years while I studied for the MCAT and applied to medical schools. And this time I was working for CDC. While I still worked on many of the same projects, I was also able to arrange for the opportunity to design my own research study in Namibia and Kenya. And this was something that I thought would be interesting and useful for PEPFAR, so that they had better data and were able to continue expanding the program. But I also thought it would be useful to get some more research before applying to medical school. So this is the third lesson that I found very helpful. Once you've found your niche and established your area of expertise, figure out what you want to do next and leverage your past experience to get there. So in my case, I was able to use my experience with the State Department to get a job working with CDC that both made an impact in people's lives and also made me a more competitive candidate for med school. And after med school, I plan to continue working in global health, but as a physician, I'll do so with a greater understanding of how global health policies and programs affect individual patients and the health and well-being of those individual patients. So this progression reflects the questions that I've been asking myself throughout my global health career, which are, where can I make a difference? What skills do I need to make that difference? And how can I get those skills? And so if you're continuously asking yourself those same questions, you'll be setting yourself up to keep moving forward in your global health career. So these are a few brief snapshots from my time working for PEPFAR. So this is a report that I made for the Cameroon Ministry of Public Health in Cameroon. And it's on the cost of preventing mother-to-child transmission of HIV. So based on the findings in this report, the government of Cameroon decided to move ahead with a new treatment strategy for HIV-positive pregnant women. And we estimated that this new strategy averted an additional 10,000 infant infections over a 5-year period. And so for me, this was a really profound example of how, regardless of whether you're working in the field or at headquarters, you can use data to make better decisions and make a huge impact in global health. On the right is a picture of me and my colleagues doing site visits at a community ART clinic in rural Namibia for my research study. And then, lest you think that all travel for global health is glamorous, this is actually what I was doing 80% of the time, sitting in a windowless conference room with the local experts, my colleagues in the field who actually understand the program, and reviewing the data to see how we can become more efficient and reach more people. So still very important, but not all glamorous. So to sum up, how do you launch your career in global health, and how do you punch above your weight when you're just starting out as a young professional? So here are 3 tips based on my own experience. The first one is that the most difficult part is just getting your foot in the door. So as I mentioned earlier, once you're within PEPFAR, there are lots of different opportunities to move between headquarters in the field or to move across agencies. But the challenge is getting that first opening. So for undergraduates and grad students here, I highly recommend applying to an internship. That's how I got my start with PEPFAR, and it's how many of my colleagues did as well. So if you're interested in working with the State Department, you have to apply 9 months ahead of time because you do need a security clearance, so just keep that in mind. But it's a great way to get your foot in the door. For grad students, I also recommend looking at the Presidential Management Fellowships. There are a lot of PMF fellows who are placed both with CDC and with the State Department, and that's another great way to get your start in government. For med students and nursing students, and everyone else here at Penn, I highly recommend working with implementing partners, and we have a fantastic opportunity through the Botswana University of Pennsylvania partnership. So everyone in PEPFAR has a lot of respect for people who have worked in the field with implementing partners, because ultimately that's what PEPFAR is all about. So if you have that firsthand experience, you're going to be a very attractive candidate to people who work on PEPFAR at the headquarters level. So next, once you do get your foot in the door, know your areas of expertise, but don't be afraid to move beyond them. So I didn't have any formal training in health economics or even clinical policy, but I was able to grow into this role thanks to on-the-job training and some really great mentors. While it was often daunting to be put in these new situations, I was able to grow tremendously by moving outside of my comfort zone. And I was given far more responsibilities than I would otherwise have had as a junior staffer. And then finally, act as a bridge across specialties, work across fields. I got my first internship and was ultimately hired with PEPFAR because I was able to connect experiences from different areas. The most successful people in my office were the people who could write a one-page policy brief for the White House one day and then turn around and write a detailed technical paper that was published in The Lancet. You have to be able to work across multiple specialties if you want to work in global health. PEPFAR employs doctors, nurses, epidemiologists, lawyers, economists, people from all different specialties. And the more that you can explain your priorities to others in language that they understand, and the more that you understand how they approach their jobs, then the more successful you'll be at achieving your own goals and moving the overall program forward. So that's a very brief overview of my experience in global health. Thanks so much for your time, and I'm happy to answer your questions.
Thank you, Ben. That was fabulous. Our last speaker will be teleconferencing in from the IHS. Here he is. This is Dr. Ryan Close. He is conferencing in from White River, Arizona. Ryan is a former internal medicine and pediatrics resident from the Hospital of the University of Pennsylvania and the Children's Hospital of Philadelphia, where he completed the Global Health Equities track. During residency, Ryan spent part of each year in the Dominican Republic, focused on pediatric anemia. Ryan now works with the White River Service Unit of the Indian Health Service as a clinician in a critical access hospital and clinical researcher working on a variety of projects. Please join me in welcoming Dr. Ryan Close.
All right, so I assume everyone can hear me? I'm going to go and take that as a yes. I thank you for inviting me, and I only have a few slides, and so I'm going to start by just sort of giving my experience of what I do. And I do a lot of teleconferencing, but this sort of setup is a little strange because I can't see anybody there, and I assume you guys can see me, so this is sort of a surreal experience. But I'll say that, you know, my desire to work in global health really blossomed from a desire to work in public health, which all started when I was a teenager. I grew up in the Houston area, and I started working and volunteering with families that were affected by HIV. And working with sort of marginalized and disenfranchised populations really moved me to want to pursue a career that was focused on public health, that would allow me to affect the outcomes of populations. And so I went on to college, and my vision for a long time was that I would eventually be a doctor, and I'd work in public health. And I really saw myself as like sort of Doctors Without Borders, boots on the ground, Paul Farmer, scaling the mountains in Haiti type of physician. And that was sort of the career path I really saw myself going. The goal was to go to medical school, get my clinical experience. At that time I probably had no idea what that really meant. And then go to another country and just treat patients and do the good work. But my passion to work with the underserved and marginalized populations led to a sort of series of internships that really changed my view of what public health meant and what global health meant. And it evolved over time, particularly medical school and before the residency. But I did a series of things that shaped the way I view how I wanted to participate in global health. The first of those was an internship in Swaziland with the Baylor International Pediatric AIDS Initiative and a PEPFAR-funded organization, at least at the time. And I was working primarily in pediatric HIV. And then later in med school, I did work with the International Center for AIDS Care and Treatment Programs, ICAP, through the medical school I was at in Ethiopia. That time I was specifically focusing on maternal HIV. And then eventually, while doing my MPH, I did a practicum in Vietnam focusing on dengue research. And through these series of experiences, I came to really appreciate a phrase that I found on the webpage for this very conference. And global health is less about geography and more of a lens through which one experiences healthcare delivery. And I think that became increasingly more true to me, especially as not only as I had more of these global health experiences, but as I was going through my specific education, which was medical school and residency, I became more clinically focused, which meant that I had an interest in population-based health, but my day-to-day work, especially as a med student and then as a resident, was patient care interactions, which I think echoes a lot of what prior speakers have said, is that you want your interventions to be either focused on the group, informed by the people that you care for, and if you can, informed by, in my case, the patients that I take care of. Not simply me showing up and having an opinion of what I think the population needs, but working with that population has informed the care that I do on a population level, which has been huge for me. And so as I ended medical school and I started residency, I really started to think hard about how do I take my skills, and develop or use them in a way that identifies problems within a population and then develop strategies that addresses those problems. And so those two foci is what informed the training I wanted to get. So, identify problems in the community. I primarily do that by being a clinician and working in patient care, and then develop strategies, and that's why I got an MPH in epidemiology, because I wanted to be able to, once I saw a problem, I wanted to be able to do something about it. So that's what inspired me to get an MPH in epi, because I wanted to be able to analyze data, speak intelligently about how you describe those problems, and then develop clinical research studies that address those problems, so that if you can implement them on a population level, if you're really successful, you're not only going to solve the problem within the community in which you work, but you will hopefully be able to generalize that solution to other populations and really make an impact to multiple populations. So that's what led me to my residency at Penn. I really only focused at places that would give me an opportunity to take my skill set to the next level. I know the trainee level is very different in the group that I'm talking to today, but one lesson, my first lesson that as I went through medical school and I went on to my next step, is when you're taking your next step, I think it's important to always think, how is medical school or medical school or residency, or from your public health education to your first job, how will this job, advance my skill set in some way? And that's what I was looking for in residency. And, I owe a lot to Penn for giving me the opportunities, which has really led me to the jobs that I have now. Because the decision to go to Penn was pretty 90% driven by the fact that they had this global health track that would ensure that I had protected time to be abroad and work in the public health sector every single year as a part of my residency. And then I wanted to do internal medicine and pediatrics because I'm population focused, and so I wanted to be able to take care of patients from cradle to grave, but also wanted to have an appreciation of the clinical needs of a whole group, not just the kids and not just the adults. Because for those of you who've got any experience in global health and public health, the needs are very different. And a lot of global health has a lot to do with peds. So that led me to the end of my residency and to the various hats that I wear now. So I'm going to switch to my slide deck. Give me 2 seconds while I figure this out. All right. Now, I am assuming that you guys can see this slide deck okay.
Yeah, we're good, Ryan. Thanks. If you can hear me. Yeah, we're good, Ryan. Thank you.
All right, great. So I'm gonna move forward. So, so I finished residency, and I really effectively I wear a few different hats now. And the primary hat that I actually wear is as a clinician, and that's working with the Indian Health Service. So, which is why sort of like I can wear plaid, have long hair and a beard, because I live in the mountains of northern Arizona. So, in the left part of this slide, you can see that there is the state of Arizona, and in sort of eastern Arizona is the White Mountain Apache tribe that lives on the Fort Apache Indian Reservation. And it's a very mountainous region. Before I moved to Arizona, I definitely thought that the place was just full of desert and cacti. But no, we are a mountainous region. I live at about 7,000 feet, and this is sort of what the terrain looks like. And on the right side, you'll see this is the Great Seal of the White Mountain Apache tribe. So that is the tribe that I primarily care for. IHS, I won't give it could, describing IHS could be, it would be like describing the VA, it would be a whole lecture in and of itself. But the idea is that there are 3 million American Indians and Alaskan Natives within the United States, and there are various Indian Health Service facilities which are either federally run and or federally supported healthcare facilities that create free healthcare for American Indians and Alaskan Natives, which moving forward I'll just say Native Americans. And often each reservation kind of has its own, at least its own clinical site. And so, if you go up to Wyoming, there's the Cheyenne and the Shoshone. Oklahoma, you have the Cherokees. In Arizona, you have Navajo and Apaches, and they're on different reservations and their own IHS sites. Navajo being the largest reservation, it's about the size of West Virginia. And our reservation, the Fort Apache Reservation, along with the San Carlos Apache tribe, is about the size of the state of Rhode Island. So, on the bottom right of the screen, you can see that this is the actual IHS facility. So this is where I get to go to work each day. It's a hospital. It has a compound in the back where people live, and it's a pretty beautiful place. But this is a population that is significantly marginalized, socioeconomically, has a lot of issues. And sort of the bottom left is sort of a typical home down on the reservation. There's a lot of garbage, broken down cars. Unemployment is over 50%. 1 in 3 homes doesn't have running water, electricity, which I find is kind of startling because these are citizens of the United States that live within the U.S. continental borders, but due to various political complications between the sovereignty that American Indian tribes retain, but still being sort of a protectorate of the United States government. There's a lot of holes, there's a lot of gaps in their care and what they receive, and it has led to massive health disparities. And we could again spend the entire day talking about the disparities in health between Native Americans and the general population. And just to name a few, it's just the fact that if you look at the top 10 infectious causes of death in the United States, the causes between Native Americans and the general population are the same. But for every single one, for all 10 of them, Native Americans die at a higher rate than the general population. And so, you know, we serve about 20,000 Apaches at our hospital. We have 35 full-time providers, and we're the only facility in which they get care. So it, you know, it's a full-functioning critical access hospital that has an ER. I function as an emergency room physician. I have an outpatient clinic. We have an inpatient ward. We have an OB delivery. We have dental. So it's supposed to be fully functioning in the sense that they can receive all the care that they need. If they're sick and they need, you know, level 2, 3 care, then we fly people out, and we probably fly someone out through our own airstrip, which is down here in the valley, or from our helipad, which is right behind the hospital, about 8 patients a day, because it's a sick population. And just some more like sort of additional Indian health service stuff is that when you work in a remote area within the United States, it often feels like you're not in the United States anymore, and that's because culturally, geographically, you feel very removed from at least where I grew up, and they're amazing people to work with and to work for, and this is just 2 pictures of things that are common on reservation. Rodeo is big here. They call rodeos bull bashes, and that's because their rodeos are unregulated. You know, people don't have to wear helmets. They allow alcohol at rodeos, so whenever there's a bull bash, the ER tends to be really busy. And on the right is something called the sunrise ceremony, which is sort of a coming-of-age ceremony that happens for young women, and it's a full 2-day event with dancing, and this is sort of a dye-colored sunflowers from the corn, and it's a really amazing experience. So, but on to sort of what I do as a clinician and as a clinician researcher within the Indian Health Service is that 60% of my job is I'm a clinician, meaning I take care of patients. I run an outpatient clinic. I run an internal medicine specialty clinic because, as I said, we're pretty remote. The closest hospital to us is 3.5 hours away. So we, you know, whatever comes to the door, we have to be able to stabilize it, treat it, and ship it out if necessary. But what actually, in truth be told, that's actually the least complicated work I do clinically, is that if someone comes in really sick, then, you know, you triage and stabilize and you get them to the next facility. And fortunately, because we are within the United States, airplanes and helicopters are readily available. And it's interesting because as a resident at Penn, which is like a tertiary care center, I was always on the receiving end of patients that needed to be transferred. But now I'm the one that's always shipping them. And so I spend a good deal of my time in the ER shipping patients out that may be too sick. But what's really actually more difficult about my job is working outpatient in a setting with a very sick population that accrues more comorbidities than the general population, and they accrue them at a younger age. So they are sicker, and they are sicker for longer. And we don't have subspecialists. There's no cardiologist. We don't have any rheumatology on site. And so I work in a setting in which I am constantly working at sort of the limit of my knowledge base and training, which is why it can be really challenging on what you do, but that's what I spend a lot of my time doing. So I run a internal medicine specialty clinic where I see renal patients, and then I'll see, you know, the next week I'll see liver patients. And so I've really had to keep up on my medicine as I've moved out here. But then what I find to be most exciting and sort of related to sort of global health is in public health is that 40% of my time is I'm the preventative medicine officer for the unit, which is a term that really means that I run public health population-based projects. I do morbidity and mortality review, and I spend a lot of my energy trying to do descriptive studies of the population that better informs how guidelines either apply or don't apply to our group. And one of the things that has been a particular passion recently is group A streptococcal infections. And so for those of you who aren't in, group A strep pyogenes, that's the, whenever you hear about it in the media, it's the thing that causes necrotizing fasciitis, but it's also the same thing that causes strep throat. And so one thing that happened when I first started working here 2 years ago was that, I just noticed that, everyone had strep throat. And anecdotally, everyone who I was working with was like, yeah, we have a lot of strep throat here. Oh, yeah, we have a lot of cellulitis and skin infections here. And my first reaction was like, but that's not normal. That is not, we are seeing these things at rates that are much higher than the general population, anecdotally, but no one had studied it yet. So I led an effort to define all rates of invasive group A strep, bacteremia, necrotizing fasciitis, etc. And I led and then I also led a group to look at rates and prevalence of non-invasive disease like strep throat and things like that. And it turns out that basically the proportion of just sore throat that is caused by strep in our adult population is twice as high as the general population, as opposed to 15%, it's more like 30 to 35%. And then our invasive group A strep disease is, the rate in the general population is somewhere between 3 to 5 per 100,000 in the population. Ours is somewhere between 120 to 140 per 100,000. So our rates are somewhere between 20 and 40 times higher than the general population, which is pretty remarkable and hadn't been studied before. And so we're trying to lead an effort on what we're going to do about this. And central to that is looking at skin and soft tissue infections. And so we are going to launch a study where we, and I think this is what's exciting about doing, getting my training at Penn, having familiarity and prior training with advanced state-of-the-art medicine, and now working in a hardship setting where I might be able to apply my knowledge base and my access to some resources to this group, is that we're going to take the point-of-care PCR testing that is currently validated for nasopharyngeal and throat samples and actually be the first site to study them for wound samples, which would be sort of revolutionary for the machine, but would have a huge impact on what we're able to do for our population, because the rates of skin and soft tissue infections are so high, we end up giving out a lot of empirical antibiotics, which then is becoming more of a popular thread in the sort of the community awareness. But antibiotic resistance, the microbiome effects of antibiotics. So we're trying to get to a place where we antibiotics our patients less. And the only way we're going to do that is we find a better way to efficiently diagnose those patients in a way that doesn't require us to give them broad-spectrum antibiotics if we don't have to. Related to that is that we're going to do a dalbavancin pilot. So dalbavancin is a fairly novel antibiotic that currently is only FDA approved for skin and soft tissue infections, but we're hoping to be one of the first sites that will trial it for osteomyelitis. That's a bone infection. And the reason this is big for us is that when you live in a city like Philadelphia and you need IV antibiotics, say twice a day or even just a few times a week, there are resources either in that city or even in your own community that allow someone to come to your house and give you IV infusions. Or perhaps you can go to a clinic and get IV infusions. We don't have that on the res, and there's no home infusion. So if someone gets discharged from a hospital in Arizona, comes back to a reservation, and they need IV antibiotics, they have to come to the hospital every single day for their IV antibiotics. Sometimes it's 2 or 3 times a day. And they don't have refrigeration or electricity on a regular basis to safely keep the antibiotics in their own home. So it's a huge limitation for us, and so we're hoping to start using these novel antibiotics for different reasons because they only require 1 or 2 doses for a 4 to 6 week period. And then we're going to be hopefully also looking at the use of naltrexone and alcoholism, because I think a lot of people have heard about substance abuse on the reservation, and it's a big problem where I work as well. It's the #1 attributable cause of death on the reservation between both patients between the ages of 18 and 35. And then exciting and sort of speaking to the interdisciplinary thread that has been common with other speakers is that our site is unique in that we have a collaboration with the Johns Hopkins Center for Native American Indian Health, and they have a satellite site that's on our compound. And so JHU is doing a ton of really exciting stuff around suicide prevention and adolescent health and vaccine studies. And just to give a plug for some of the exciting stuff that Hopkins has done specifically with the White Mountain Apache tribe is the HIB vaccine. Probably everyone in the room, except for a few, myself included, does not remember when HIB was a big deal. It used to be the #1 cause of bacterial meningitis in the world, or bacterial meningitis-related deaths in the world. And the original vaccine studies were done on the White Mountain Apache tribe. And turned out that then had huge worldwide population effects. Also, oral rehydration solution was first created and studied on the Florida Apache Reservation decades ago through this joint collaboration with the Hopkins School of Public Health. So working locally within the United States with a hardship, in a hardship setting with a needy population, you can do work and research that ends up having worldwide implications. And I found that really exciting, which is what led me to come work here at IHS to sort of pursue work that I think is important, that could be important to other populations as well. So beyond that, the other hat that I wear is that I'm still on faculty at Penn. And so this is the work that I do down in the Dominican Republic. And sort of backtracking before I ended up at IHS is that during my residency, as I said, I came to Penn because I wanted to do global health work. And the site that I ended up landing at was in Dominican Republic in the town of Consuelo. And this is the clinic at the top. And this is the clinic for the whole town, but within this clinic is a pediatric clinic called Niños Primeros en Salud. And that is a joint collaboration between CHOP and this specific clinic. And when I started going there, now many years ago, I was in clinic one day, and I sort of tell the story because it sort of speaks to also what some of the other speakers said about be aware of your surroundings and just sort of like go and immerse yourself in a population in which you want to work and pay attention to things that might be affecting them, even if someone else hasn't thought it yet. And, kids, the rate of infectious illness there is really high, and they don't have a great deal of resources, but, they do have a lab. And so something that was happening often is that a kid would come in with grippe, which is like their version of, they have a flu-like illness, and they often get CBCs because they would use the CBCs to try and help them differentiate their risk of thinking whether those children had maybe a more severe bacterial infection or something else. But I noticed that every single CBC that came across, the kids were profoundly anemic. The blood counts were very, very low. And then we just started poking around and asking, like, hey, like, what's the rate of anemia here? And sort of anecdotally, again, people were like, yeah, all our kids are anemic, and we're not really, we don't do much about it. And we have iron, and we give iron when we see that they're anemic. But no one had really described it. And so therein started a sort of multi-year progression where we did one sort of small study at a time that served as sort of a foundation and small building blocks. And the first thing we did was just a basic chart review that we published in Global Health Annals that was just sort of describing the rates of anemia and in the population, which was 80% among children under the age of 5. And that just basically tells you that if that many of the children under the age of 5 are anemic, you can just about guarantee 100% of all those kids are iron deficient. And so the question becomes, all right, so what are we going to do about this? We needed to better define the problem, and we need to think about sustainable solutions, because the WHO recommends that when iron deficiency is so profound that you should actually just treat everybody. But to treat people with oral iron, you need a clinic, you need oral iron, you need enough of it to give every single kid every other month through the first 5 years of life. That does not sound very sustainable. It's also not incredibly cost effective, because while oral iron is not expensive on our terms, when you're talking about a clinic that's trying to battle multiple diseases on multiple fronts, including things like dengue and chikungunya, and now Zika down in the DR, iron deficiency is not the top of their priorities, even though it is one of the most common morbidities on the planet, and it's a significant one. When you're saying, oh, you need to buy a bunch of iron and make sure everyone's taking it, and if you've ever had oral iron, it is not pleasant, especially when it's in the liquid form for a child. It's gross. So we had to think, well, let's define our study. So in the bottom right, that is a poster that we presented at PAS last year. On the far right is Andrew Sinoff. He's the director of CHOP's Global Health Center. And then the two girls in the middle are Maria and Clarice, who are Global Health Fellows at CHOP. Maria's now moved on and is working in Botswana at the Botswana UPenn Partnership. And on the left is me and Steve McKee, we were both residents in the MedPeds program at Penn. And the poster we presented was describing the massive deficiency in dietary iron, because naturally, when we told everyone that the kids were anemic, we had a bunch of feedback come back to us from funders that, well, how do you know it's not parasites, and how do you know it's not this? So we did a big full investigation, cross-sectional study that looked at actually measuring and quantifying the amount of iron. And so in doing so, we were able to sort of prove that there was grossly insufficient amount of iron in these children's diets. So then we started thinking about what are we going to do about it? So that's what's on the bottom left. So we are now doing 2 randomized control trials where we provide this iron fish. It's about the size of a bar of soap. I think I might have one right here if I'm not on the screen. Ooh, shit, sorry. It's a little piece of iron. It's small, about the size of a bar of soap. And basically what we do is we give it to families, and they boil it in the water, because the Dominican diet is a common sort of Hispanic and Latin diet, also common in Southeast Asia, where you boil water, and then in that boiled water you either drink it because the water in the local area is not safe to drink, or you use it for your food, predominantly rice. And rice is a phytate, meaning that it leads to the inhibition of iron absorption. So even if children are having beans and other aspects of the diet that might have iron in them, if you eat a lot of rice and you eat a lot of other phytates, it means the bioavailability of your iron is very low. So this is a way to bolster the iron content of those meals, because we can't fundamentally give everyone iron-rich food. I don't have the capacity to go to the local markets and change the economy around food opportunities there. That is an important goal, and that's something that we hope the local community will focus on, but can't change that through my clinic. So how can we provide sustainable iron? And so when you boil this iron fish for 10 minutes in a liter of water, it provides the equivalent of an entire pill of iron. And if you do that every single day, it bolsters the iron content quite a bit. And so we have 2 studies going on where we took children under the age of 5 who were already anemic, and we randomized them to receive this or standard of care, and we're going to see if it works as good. And that data collection is going to finish in the next 5 to 6 months, and actually one of our first posters is going to be presented by a Penn medical student at PAS in Toronto this May, Nahara Ceballos. And the preliminary results are pretty good, that it is currently as good, if not maybe a little bit better, than oral iron, but I can't say that officially. But the benefit is that one fish lasts the family a minimum of 5 years, and it only costs $5 to make. So that's pretty sustainable. And we've had good acceptance of the use of the fish, and really promising results so far. So that has led to us launching another RCT, which is now focusing on, we're going to enroll more families, and we're going to use a bigger part of the community. And what we're going to do is we're going to recruit mothers of newborns, and we're going to give them this fish right after birth and follow those newborns over the course of a year, and see if we can prevent iron deficiency of infancy, iron deficiency anemia of infancy, because the research is pretty solid that if you are iron deficient in infancy, you have neurological, neurodevelopmental issues. So, you lose IQ points and you don't get them back. And so that has a lot to do with the fact that there's massive brain growth during that time, and iron is used in a higher quantity from 9 to 15 months than any other point in your life. So we need to make sure that these infants have sufficient amount of irons. So that is what I'm doing down in DR, and I think it's exciting stuff. And I love that after residency, I was able to stay on at Penn to continue to do this work down in the DR and find a job that sort of suits my personal and professional lifestyle in IHS. And IHS isn't just some like, oh, clinical job I do, but I'm also doing research in the DR. I'm applying the skills and lessons I've learned from the DR and various other places globally, and now I'm using them with the needy population that's here in the United States. That still allows me to live locally and up in the mountains of Arizona. So I'll say that my one of my the lessons from my experience that I'll say is that be persistent and be bold. You never know what people are going to say, and what I mean by that is that if you have an idea or if you want to try something or you want to get your foot in the door, you should always just ask. And my two experiences are that this ironfish project I'm doing in the DR, I read about the ironfish in the Atlantic magazine, and I simply just tracked down who the inventor was, and I just emailed them. And I said, hey, I'm a trainee down in the Dominican Republic, and I think this ironfish thing sounds exciting, and it sounds like you've never done anything about it in children before. So how about we partner together, and you let us use your product, and we'll study it in kids for the first time. And they said, great, let's do it. And I think that was really important. And then same thing with the Vietnam, where I wanted to do some infectious disease, global health research, and the way I got to Vietnam was not through any connections to my medical school, but I just emailed a leading author on dengue research. He lived in London. He connected me with a hospital that he worked at in Ho Chi Minh, and that's how I ended up there. And people are willing to help trainees. I think you should never underestimate your power, that no one has any suspicion of trainees, that you have some other ulterior motive other than to just learn and gain some global health experience. And I think global health community likes to help each other. So always be willing to just reach out and ask to try something new, especially pushing limits. So that really was my second point, which is to be adventurous with opportunities as they present themselves. And then 3 is that, and I think other speakers echoed this, is that you need sample a lot of things as you go through your training and you sort of emerge in your career. But at some point you should transition from the quick fix study to being invested in longitudinal projects. When you find something that you think is worth investing in that may help a population, be willing to sort of take the risk of investing in something long term that might have a real impact on the population, because it might turn out to be a real career changer. I am not a hematologist, but now I do a lot of anemia work, and if you had told me 10 years ago that I would be sort of a pediatric iron deficiency anemia global health expert, I would have laughed, but that's where I am now, and I love what I do, and I love who I work with. And so that's really all I got to say, and I appreciate everyone's time, and I will creepily stay up here on the screen if I need to take questions.
Let's give Ryan a round of applause. Thank you. Ryan, that was great, as always. Thank you. I'd like to invite Hannah and Ben to come up for a quick panel since we're running a little bit over on our time. We're just going to take maybe 2 to 3 questions from the audience. If you have a question for either Ryan, Ben, or Hannah, please raise your hand, and Tazeen or Amy will bring you the mic, and you can direct your question to all 3 panelists or to someone in particular. So are there any questions? No questions. Okay, I have some questions for our panelists. Oh, here's a question up here.
Hi, I'm Brian. I'm an undergrad student in Penn, and I had a question for Ben. Given what you've heard from a variety of the other speakers and such about the importance of meeting with patients and learning from them and then making the policy afterward, and it seems like you had found that idea later on, what would you have changed, or what will you change in the future about like the policies you have, or the models you have created for these health patterns and like the places you worked? Does that make sense?
Yeah, thank you. That's a great question. And it's also a big part of the reason why I'm here in medical school. because as I was working on these global health policies at a high level and developing these models to project what global health programs can actually do, what I realized is that in order to really make a difference in global health, you have to understand how these policies are going to affect individual patients. And that was experience that I was lacking and that I felt would be really important if I wanted to continue working. Can you guys hear me okay? And so that's why I decided that I wanted to become a physician. Looking back in hindsight, something that I was very cognizant of throughout my work in different countries was the fact that I wasn't there as the expert. The people who really knew the programs, who knew how these policies affected patients, were the local physicians, nurses, public health officials who lived in these communities and had been practicing these communities for, decades. And so my role wasn't to tell them how to do their jobs. It was to say, look, you know a lot about infectious diseases and about this community, but you probably don't know how to build a model that projects the costs of a program over 5 years. So let me help you with that so that you can take everything that you know and use this additional information to make the best possible decisions for your program.
Great. Are there any other questions? Yeah.
Hello, good morning. This question is for Ryan, and I think it's really admirable that you use the iron fish in trying to address the problem of anemia in the community that you're in the Dominican Republic. I understand that the project that you embarked on was with infants, and I'm curious how your iron supplementation model interacted with breastfeeding practices or bottle feeding or the type of infant feeding practices that you observed in the community that you're in.
No, that's a good question, and I think the way that so far we have a robust. This is a project that was started a long time ago by one of the previous fellows. Is that breastfeeding is really common there, and a lot of it's just because formula is expensive. So we give the iron fish to the mothers of newborns because we want to capture them early, and because well-child visits and care is not a common thing in these sort of settings. They don't bring their kids in commonly for their 1 month, their 2 month, their 6 month well-child check. And so we were worried that if we didn't intervene basically right after birth to try and get them this iron fish, that we would miss an opportunity to be able to provide that iron fish at a time when they were doing dietary transition. So for those and for everyone in the room, basically, we do not feel that the current iron fish as it is given to mothers of newborns is in any way changing how they are feeding their child, meaning they're breastfeeding exclusively, and that is the primary way they're getting nutrients. The goal is that mom and family are using the iron fish, even though that the infant is not using any of the water or the food that is being made at that time, at least. But it is supplementing mom who has high iron needs because, I didn't say this earlier, but all the women of childbearing age are also iron deficient in this population. And iron deficient mothers have insufficient iron supply in their breast. And so our hypothetical intervention is twofold. We increase the iron content of the food that goes to the mom, and then at the point that that child transitions from breast milk to some table food after 6 months, the family is already used to using the iron fish as the diet for the family, and that will start supplementing the iron quality of the food that the infant will start receiving after 6 months of exclusive breastfeeding.
Great, thank you. I think we can take one more question before we move on to the next panel, if anyone has a question. No? Okay, well, in the back of the program, all of the speakers have provided their email addresses, so if you have additional questions, please feel free to reach out. They'd be happy to hear from you. So I'd sincerely like to thank all of our speakers, Ben, Hannah, and Ryan. Thank you for sharing your experiences with us. And I'm very pleased to invite back up Corrado to moderate the next panel on local and global public health research. So one more round of applause for our speakers. So they will, so you can just introduce Elon. Elon will be going first, and he'll come up and give his presentation, and then you can just ask whatever questions.
Let's do it like this. So we are entering the third section of today. We have two very distinguished speakers. We'll start with Ilan Moss, and then we'll move to Boris Stephen. Ilan Moss is a journalist that has 15 years of experience working with international development agencies and NGOs, and he's currently working with MSF in New York on the development of drugs for neglected tropical diseases. So the detailed biography is here. So Ilan, please welcome.
Hi everyone. Let's get this. So there's, my affiliation with the school here is actually really interesting. Was it 3 years ago? We held an event here. And this was an event on filarial diseases, river blindness. We all know river blindness. And this was a pretty important event. It was around the ASTMH conference. And we were really bringing attention, and I'm going to talk about, storytelling and how important communications is for global health. But just after, I got to go from Penn. We held this really important event with clinicians from all over Sub-Saharan Africa, the US, and Europe. And then I was here in an endemic area of the Democratic Republic of Congo, DRC, with some local health workers that actually distribute drugs for river blindness. And that's global health for me. From the conference hall to, this is Chopo province. This is pretty close to where the Ebola outbreak was a couple of years ago, which I worked on a little bit. So that's global health, not in a nutshell, but let me go on. So I guess I'm a bit of a wild card though here, because I don't have an MPH. I do have a master's. I got it about 4,000 years ago at the London School of Economics. But I was a journalist for a long time. I was a print journalist. I worked in video journalism. I even did some social media stuff. And around 2008, a lot of you will know, I think you're still old enough to remember those times, but there was a crisis in journalism. The newspapers were laying off. We were seeing a whole change in the business model of journalism. I myself had a crisis. I was actually in Tanzania. I was reporting on the refugee crisis in a part of Tanzania, which is on the border of Burundi and the DRC. And I was covering malaria, and I sort of met some workers from actually the Spanish Red Cross who said, "Oh, you should go work in communications, it's great." So I was just worried about selling out and working for a big agency. But my training is as a journalist. It was and still informs everything that I do. So in global health, you have all sorts of technical skill sets. But I feel like the skill sets I learned working in a newsroom, having an editor, being on deadline actually really helped me a lot in my job. They help me every day. I don't know if any of you have ever done any journalism. I think now, storytelling is becoming the norm, so of course we're all involved in that, but I was sort of, from that old school, and I'm proud of it. But I did go from journalism to the WHO. I wore a couple hats in the WHO. I was at an organization called UNITAID, which some of you might know about. It's a funding agency, sort of a lesser-known funding agency of the WHO that's financed by a tax on air tickets in about 11 countries. And then I was working for the different sort of partnerships in the WHO on TB, on malaria, always in communications. So always storytelling of some sorts. And it was great. I really liked it. I think the examples here, I was based in Myanmar for a bit, working on drug-resistant TB. It was a really amazing experience for me. I was in Mozambique, doing some official comms, but also working with communities. I liked it, but when the opportunity to jump ship to something else like MSF presented itself, I just got the hell out. No, I made a very, smooth change. It was around the time of the Ebola outbreak when I did, was seeing in the field how MSF was working in West Africa, and I had to join it. And I'm happier. I'm less paid. But it was a really great career change for me. I still think the WHO is an absolutely vital, no one will disagree with me. I think the new leadership is really interesting as well. But for me personally, as a storyteller, I felt a little more flexibility, in the MSF world. So the last two bits there, that's in Orissa or Odisha province in India, where I worked for a while on lymphatic filariasis. And below, that's an MSF project in Malawi that I worked in for a little bit on pediatric and second-line HIV. And when they asked me to find some photos about myself, in the field, I kind of realized I only had one shirt. So sorry, I gotta diversify my wardrobe a little bit. But so MSF, who has heard of MSF here? Just raise your hands. Okay, so everyone. DNDI, the Drugs for Neglected Diseases Initiative? 0. There you go. So I think this photo here that really sums up what we are. So you see this is a site, if you work in any low resource country where there's conflict, you'll see the MSF car, and you'll see the, the no arms sign, which you actually have down here in this university. So it's a common, it's to show that we're a non-aligned, we're not aligned with the military, we're not aligned with any governments, we take very little money from governments. That's what you see on the top of the car. On the side of the car is something else. This is the Drugs for Neglected Diseases Initiative, DNDI. We were created by MSF. We're actually sort of housed by them. I work in New York in the DNDI North America office, and it's part of MSF. We're in the same building. I sit next to the field HR department of MSF. So there's lots of back and forth, but we are different because we partner with the pharmaceutical industry. And MSF obviously is not going to partner with the, with the pharmaceutical industry, but that's part of our business model, which I'll talk about. And I sort of just listed off some of my tasks at DNDI, but it's communications. This is something a little different than we talked about today, but media is obviously really important. There still are some journalists covering global health, and I sort of coordinate a global team of communication specialists in about 7 different regions. And, we divide things between sort of, working with the more general public correspondence and working with the scientific media. Trying to build the capacity, actually, of the scientific media in some of these endemic countries. Extremely important. Science is science. And science journalism is crucial for science. I mean, we all know about journals. But there's a whole other, world of specialized scientific journalists that report on results. And that's still important despite what's happening with journalism. So that's a lot of what I do. Digital media, obviously I run a team of digital media specialists who are not at all from public health, but they're getting a baptism in fire. We do social media, we do, you guys know about this, I don't need to tell you. But events and scientific communications are key. So dealing with our research, and I'll go a little bit, I hope I don't go over my time, but we do a lot of, obviously do research for our research-based organization. That gets translated to publications, to scientific results, to conferences. I sort of coordinate everything. It's very special with DNDI because we're committed to open results. We're committed to publishing everything, to being transparent to the degree we can be. So I need to ensure that, from that journals go into open source, or that our publications are open source, that anyone can access them. Also ensuring that there's, sort of a fair representation in so-called endemic countries. It's a whole other skill set that if you didn't understand the science and you didn't understand what makes global health what it is, you wouldn't be able to do it. So I think my sort of 10 years now in global health helped me a lot with that bit. And there's something called, we call it ICE. It's also known as behavior change communications. This is working in communities to develop tools that are appropriate to these, low resource settings to pass on essential public health messages. Now with clinical trials, it's special because we're running clinical trials in so-called endemic countries, and we need to talk to the communities. We're going in, we're testing, we being the local offices of D&DI, which are entirely staffed by D&DI. I'll go a little into D&DI in a bit, but we need to talk to patients, tell them, that we're not just testing drugs on them, that these are essential interventions that are, going to help their community. We also need to recruit for these clinical trials that involves communication. So there's this whole body of communications. And because of the diseases that we're working on, which are neglected tropical diseases, I'm kind of brought in as well to help other actors with their public health communications campaigns. So I worked a lot on Ebola. I've worked in the DRC on emerging outbreaks. So working with the Congolese Ministry of Health, developing specific communications campaigns. Now, I was telling a story earlier about some communications material I found from monkeypox in the DRC this December. It was a binder basically of sort of water-stained, printouts in English and in French. I mean, that does not work in remote regions and in the DRC. You need radio, you need really specific tools to get out there and reach people. So part of my job is developing those as well with local partners as well. And I just, I talked a little bit about some skill sets. So this is me in actually Mozambique when I was still a journalist, when I was making that transition to covering global health stories and then actually getting hired by the WHO, which probably was some sort of ethical breach, but I never actually was doing both at the same time. I was just, doing my job as a reporter and then realizing that I wanted to go into global health. So this is at a DRTB ward in southern Mozambique. And I really use all these skill sets that I developed over years of working as a reporter, of having deadlines, of having editors screaming at me. Those still help me in translating scientific results from my organization into communications, into a human story. And I mean, storytelling is really used a lot now. I think it's, a lot of advertising agencies use it as a way to get clients. For us, it's really telling the story of the people behind these neglected diseases and moving people to act, to either give money. It's obviously one part of what we do, but it's not everything. But to move political actors. It's global health. This is something everyone has talked, everyone has spoken to, but what makes it global is the political aspect as well. And that's why, I think communications really plays a role in convincing these actors and helping our scientists as well argue their case. Messaging is, I think everyone that spoke today was fantastic at messaging. That can be rare actually, especially in MSF, that can be, very patient focused, and sometimes you put them up in front of people or even tell them to publish something and it's all over the place. You need to speak to people. So there's a role for people like us to help them do that. And then I, spoke a little about, behavior change or ICE. And I just wanted to touch on really briefly about this sort of global aspect. So, it is global health. And I think everyone today has touched on the fact that, we need to be looking locally as well, and experience you can get locally. So in our case, we're working on hepatitis C. You all know MSF as well. It was founded by journalists, but also activists and doctors. So there's always an activist tinge to what we're doing. And the crisis in biomedical innovation does not only exist in the DRC, it exists down the street, where people aren't able to access hepatitis C medicines because they cost $1,000 a pill. It exists in antimicrobial resistance, where we haven't developed new antibiotics forever because it doesn't constitute a market for a lot of pharma companies. And it exists in cancer as well, where medicines are priced too high for a lot of patients and governments. So, seeing that global aspect, seeing what links the crisis in the US to around the world really helps, I think, in understanding like this, the fact that we are working in global public health. But then you have to have global skill sets. I mean, I lived out from my parents were immigrants, but I was, brought up in the US. But I lived over a decade abroad. I speak French fluently. I recommend French always. It still is a vital language in global health. There's lots of other languages, but unfortunately, a lot of these organizations are based in Geneva. And it is actually a growing language in a lot of countries. You can go from Goma on one side of DRC to Kinshasa, speaking French the entire time in a country that's the size of Western Europe. It's incredible. And it's learning to work in these environments as well. So we're a little far from the rest of the world, I realize, in America, and we need to learn how to work with multilateral, with diverse and, with teams from people from all over the place. That's the best thing about the UN that I learned, I think, was my team was, it was from everywhere. This is classic UN, this is WHO. And I think I really learned some key skills in how to work across, with different everything. And that's absolutely vital to WHO, to global health. And then, I mentioned language. I learned some other stuff as well. A little Swahili, kidogo Kiswahili, but I can do better, but maybe I'll do better next month. But I wanted to speak about one neglected tropical disease as sort of an example of something that I've done that I'm really proud of. That's not just me, but it is sort of a collective of people. Has anyone heard of mycetoma in here? 0? 1. Okay, so this is one of the world's most neglected tropical diseases. It's a devastating fungal or bacterial infection. The fungal version is often transmitted by a thorn prick. So if anyone's ever seen acacia trees, they have thorns that are about this big. There's a mycetoma belt. I'm not going to go too much into the disease, but there is Sudan is actually home to anywhere between 60 and 80% of the cases of fungal mycetoma. It is an absolutely devastating illness. The thorns fall to the ground, they mix with the agent, this is what's thought, and then people that walk barefoot walk on the thorns and it's transmitted. The fungus actually grows into spore-emitting lesions which make their way up your body, and it is fatal if without treatment. And we'll get back to the treatment bit. So this is just the case. This is a place that I worked in Sudan, in Khartoum, for for a couple of months. And you see a patient there, and then everyone did sign, obviously, forms here that everyone gave their permission to show their photos. And you can see it's a little hard, but if you see that obviously this is an amputation. He had gotten 2 amputations, received 2 courses of the only treatment used now, itraconazole. And you can see lesions, if you just look over here. So even after 2 amputations and after 2 courses of heavily toxic treatment, it came back. So he wasn't cured, and it's slowly going up his body. So literally, the doctors in Sudan are forced just to cut, and treat with very poor, very toxic, and expensive medicines as well, because not only because of of sanctions against the Sudanese government, lots of things are a lot more expensive there. So this is a disease which no one knows about, which has horrible treatment options, and is as neglected as you can get. You can see this is a case from a gentleman from the south, from the Blue Nile region of Sudan, not South Sudan, of Sudan. So you kind of see this is sort of a better case of mycetoma. So those are all fungal lesions. They go up the leg. This was a farmer who he knows how he was infected. In fact, he thinks that a goat stepped on his foot, and then he had an open wound, and then he was just walking on the soil and got infected. And my job, so obviously our job as a drug development organization is to develop drugs for this neglected diseases, my job is to raise awareness about this disease that absolutely no one talks about, that's in a country that a lot of people don't want to touch, which was Sudan. And this was actually a big challenge. Why was this a challenge? And this is, so just to give you an idea, this is a village in the in Jazeera State, which is the south of Khartoum. And I asked a gentleman, and he wrote down the names of all the amputations that had happened in one village of 1,500 people in 1 year. And it is, as I said, it's a devastating illness, but it's not on a list, and that list is the World Health Organization Neglected Tropical Disease List. It's extremely important to be on this list. So that's one list. And this is an old screenshot from the WHO NTD page. This is a list of what they consider to be neglected tropical diseases. So mycetoma was not considered to be a disease, even though it's as neglected as you can possibly imagine. It's also, by the way, tropical. And last time we checked, it was a disease as well. Yet, because of lots of political reasons, lots of reasons, it wasn't put on this list. So finally, after some advocacy, it was stuck under, they kind of put it on as another neglected condition. So what did we do? We actually led a pretty big campaign to raise awareness about this disease. So working hand in hand with, I'll go into this in a second, with our, our partners in Sudan, and with a group of, actually, you've heard of UAIM, I'm assuming? Universities Allied for Essential Medicines. This is I can give you more information on this. This is a global student group committed to access to essential medicines. We held events during the World Health Assembly in Geneva. I did I went with reporters to Sudan, which was a challenge to bring in Western reporters into Sudan. Not because it's a dangerous country, it's completely, at least the parts we were working in, not safe, but fine, but it was just getting permits and getting these journalists in, developing everything I talked about, being a communicator, basically. So, we were, obviously there's a really bad picture of me on a video in the Huffington Post. We did a social media campaign. We got Nick Kristof tweeting about it. NPR, we worked with a great service called Global Health Now, which is part of Johns Hopkins University. Is anyone a subscriber to Global Health Now? Okay. So they did a series on mycetoma, which, again, I'm not taking credit. Well, I'm sort of taking credit, but we helped pitch. And, it was linked to our R&D efforts. And this is just, we had to pay credit to the sort of group of people who sort of spearheaded this. In the middle, you see Professor Fahal, who's the head of the Mycetoma Research Center in Khartoum. He's also it is the only specialized center for mycetoma in the world. So patients that are infected from Mexico to Chad or Somalia onto the Gulf, from all over the Gulf region where it's still a little endemic, they'll go to Sudan to get their treatment. He's Skyped me from Barbados before, which is kind of a surprise. He's brought around the world, but this is the only place that treats that, and he helped us with this effort. Some local students also, helped in this effort, but it was as interdisciplinary as you can get. And then, finally, it was this, sort of essential moment. We actually got the disease on the list. It actually happened. So if you look at Global Health Now, they did a whole series on how sort of this set of partners worked together over years to get this disease on a list. It sounds very simple, but what does that mean? That means that now that it's considered a neglected tropical disease, it can get funding. The CDC has started already a working group on mycetoma. There's been some visits to Sudan. I mean, we're starting to, I think, unveil the neglect a little bit. And as I'm not a clinician, I'm not a research person, but, I really did feel that I was contributing to the R&D process by putting this disease on a list. And it really was probably one of my proudest moments in my career. I'm just going to go really briefly onto D&DI because again, you know MSF, no one knows D&DI, and we're hiring. A lot of the other people might not be hiring as much, but product development partnerships, it's a horrible word. I'm hoping that we'll find a new word at some point, but these are basically partnerships between, I mean, there you go. It's pharma, but it's a not-for-profit model to develop drugs and diagnostics and vaccines for neglected or for a whole range of diseases. D&DI, I'm going to speak about them. MMV is malaria. TB Alliance is in New York. It's TB. PATH is everywhere. I don't even know where they are. I mean, I know where they are, but they're in Seattle, but they're everywhere. They do a whole load of development. And FIND, who unfortunately is a little hidden there, and they always feel like they're hidden, so maybe that's appropriate. We should actually just move it over and cover them, because they do diagnostics, and no one cares about diagnostics, so they always feel really sad and underappreciated, but they do great work. But there's a lot of other ones. I just listed the ones that I work with a lot. But let me go into D&DI. You can read that. I don't need to read off all of the stats, but just to show exactly what we're doing. We were created by MSF. When they won the Nobel Peace Prize, they used that money to create the Drugs for Neglected Diseases Working Group, which then created D&DI. They teamed up with basically the NIHs of a set of endemic countries. So the Kenyan KEMRI, which is the Kenyan Medical Research Institute, the Indian Council of Medical Research, the Institut Pasteur in France, Fiocruz in Brazil. This is a really important organization in Brazil. The Malaysian Ministry of Health. Basically, these partners created what we always like to call now sort of a conductor of a virtual orchestra of partners working for neglected diseases. What are those diseases? Hepatitis C, no time to talk about it, but in a month you might hear about it because we'll be releasing results of a trial for an affordable combination for hepatitis C that we're running in Malaysia. Mycetoma, we just spoke about it. Chagas disease, this is the disease of the Americas. We're running trials in 6 countries in Latin America. Malaria, we've actually left, but we developed 2 of the first FDCs ever recommended by the WHO a while ago, ASMQ and AZEC. Those are 2 FDCs that, well, at least one you'll see in a lot of different places in sub-Saharan Africa and Southeast Asia. Sleeping sickness, we're running trials in the DRC. Over there, I skipped over it, but that's leash. It's in all over the world. There's Kala-Azar in India and East Africa, but there's also a cutaneous version in Latin America and in the Middle East. Now I'm jumping. Filarial diseases, river blindness. Pediatric HIV. Obviously, HIV is not a neglected disease, but the pediatric version of HIV is a very neglected disease. There's a treatment gap between adults and kids, and one of the reasons is because of horrible, poorly formulated regimens for kids. So we're working on a more child-friendly version. Just to give an idea of where we are around the world, it's a real, it is sort of a virtual orchestra. We do have lots of staff, but we have many more actual partners who are working for our trials, doing from preclinical to implementation. And importantly, we work with the pharmaceutical industry, as I said, and they give in-kind contributions to us. So some staff will be working full-time for 2 years on D&DI projects. But importantly, we also work with, universities. A lot of our projects are based on compounds that never made it into pharma, that came right out of compound libraries from universities. And now we're pushing them through clinical trials. I think this is my last slide, which is ugly, but it's important. I had to grab someone from our HR department and shake them to get this slide. So this is top secret. No, but so we are hiring a lot. So these are some areas we're hiring in. These are 3 sort of, what did I choose? I chose officer, manager, and senior manager. Because I didn't put this, the lower level jobs. I didn't want to put director. I'm sure there's some directors here. Just to give an idea of the skill sets we're looking for. So we're doing the neglected tropical diseases. As I said, the diseases we mentioned, we're looking for all sorts of, from clinical to more policy, obviously MDs for some of the trials, trial manager positions. And then, my last little bit, sorry if I'm going over, we've partnered with the WHO to create an organization called GARD-P, which is the Global Antibiotic Research and Development Partnership. It's based in Geneva, and the idea is to use the D&DI model, so not-for-profit drug development, to develop antibiotics. So we have 3 projects right now. So for drug-resistant gonorrhea, neonatal sepsis, and sort of an antibiotic recovery initiative. We're hiring like crazy for that. Now this is an antibiotic research. It's kind of like the flavor of the month in a lot of countries in the UK. Obviously the UK government, but Germany just gave us a $60 million or 60 million euro grant. It is a critical area of research right now. There is no antibiotics. Just 3 days ago, a case showed up in the UK of someone fully resistant to the last two antibiotics for gonorrhea. So, if you my email's there if you have any questions on D&DI specifically. And that's beyond communications. We're obviously hiring, but I don't know if there's any people that would want to go into communications. But if I just sort of sum up, since everyone's done that, we are a service provider, I think, to all, and we being, working in fundraising, working in comms, working in policy. We are a service provider, but the more skilled people that enter into that world, even MDs or people that did, public health, I think the richer we can continue our work in storytelling, but that will continue to be staffed by people that have a communication skill set. So I don't know if they're going to be journalists. I mean, I have journalists that come to me, looking to move on, and I'll hire them in 2 seconds because it still is a skill set. I think storytelling is something that global health needs. We know about the funding gap. We have a lot of work in this country, around the world, in telling the story of what we're doing. And we shouldn't just see it as a service provider. I think we're an essential service in global health. And feel free to take a photo of that, and if you have any questions. Thanks.
Well, thank you so much, Leone. It was a great talk. Thank you for talking about Madura feet, which is indeed a very neglected disease, and it's devastating. Very interesting to hear about the role of pharmaceutical companies in global health, the importance of communication, just to emphasize the point that you can really engage in global health from so many different angles. And then great to hear about your personal experience, starting out as a journalist, moving on to the WHO, now doing communication for the drug development arm of an international NGO. This notion that you have to be open-minded, resilient, entrepreneurial, and if you're committed to global health, good things will happen. So thank you. We have another very distinguished speaker, a fellow European from Germany, University of Bonn, Professor Boris Steven, who has a PhD in biochemistry, studied Marburg virus, which is a virus very closely related to Ebola early on, and over the past 15 years has been studying parasites. I think currently you're focusing on Cryptosporidium, which is a parasite that causes severe diarrhea in children, especially in developing countries, and in HIV patients. So again, that's another angle, like the basic sciences or translational research, in which you can engage and still do meaningful and important work in global health. So thank you.
Thank you so much for having me at this, and I should start with an apology. When I was asked, would you come to a career work roundtable on a Saturday? I said, yeah, great, I do this. And I thought, well, I sit at the table, and 3 or 4 of you guys sit on the other side of the table. So I didn't bring you a lecture with slides, which is a great experience for me because as a career academic, I always speak with slides. And the last time I spoke without slides was at the wedding of my little sister. So So if I had brought your slides, undoubtedly they would have been centered around the molecular biology that my lab does around this parasitic disease, Cryptosporidium. But as almost every speaker before me has pointed out how they had an interaction with basic research and then found out that it's not for them, I thought, well, maybe it's a good thing that I didn't bring you my slides. And so I thought maybe we start out and I ask you, so if you would have to figure out, what's more important to global health, kind of basic research or, public health and implementation. What do you think? Who would think public health and implementation is more important than? You can be honest. Come on, people. All right. So you guys. And so, well, let me flip it. Who thinks fundamental research is more important? I guess so you don't have an opinion on this. Okay. All right. So I think a good way to I think in this field, as in many other fields, that is a very, very deep divide. Even on this campus. So I just arrived on this campus, a few months ago. And there are many people here who do fundamental research, for example, on parasites and other infectious diseases. And there are many people who do global health on a more implementation level, and there's not that much of interaction. And so if you in your mind had voted for no need for basic research on these diseases, I think you should contrast that with your views, for example, on cancer, right? If you'd say, okay, let's look at the U.S. investment in cancer as a disease. Do we need trained physicians, and do we need public health initiatives to promote healthier behaviors like smoking cessation or things like that, or do we need fundamental research that at some point will give us new therapies like CAR-T? And then you would say, well, obviously we need both, right? Especially if I had a cancer like lung cancer where prognosis is still really poor, I would be really interested in more research. And I think many of the traditional kind of global health diseases fall into this category where there are still the treatment options are really quite are either quite poor, or they are massively threatened by the emergence of drug resistance, like in the case of malaria. Okay, so I thought maybe I quickly tell you how I came to do what I do, and then maybe I tell you a little bit what we really do, and then I hope at the end, like everybody else, I can figure out 3 useful things to say to get myself out of this. Okay, so as a tropical disease researcher, I come from the least tropical places in the world. So I am German, and I was born and raised in Duisburg, which is a harbor on the Rhine that brought the ore to the German steel mills when Germany still had a steel industry. So I come from a really super industrial neighborhood where everything was gray and coal dust. And then nobody in my family had any relationship to science, so I'm the first scientist in my family. And I thought, I want to be a biologist. And I went to the University of Bonn and I studied zoology and botany. And I just by happenstance walked into a lecture on parasites and tropical diseases. And to the chagrin of all students, all of these parasites have these super complicated life cycles, right? Where you have to remember, okay, and then the mosquito, and then they go to the liver, and so on. And I was immediately fascinated by that. As a biologist, I thought, wow, these are really super interesting organisms, and also there's really some significant need to advance that field. So I started to study parasites, and I was really, I think scientific careers are like scientific papers, right? So you may, if you write, I don't know, did anybody, who published a science paper? Yeah. Nobody? Okay, a few. Okay, cool. Okay, so the way it usually works is that you make a number of observations, then you do a few more guided experiments, and then you sit down to write the paper, and you try to come up with a story that makes sense. Okay, so you put it all together, and I think science careers, as you've heard several times today, are like that. So the reason that my next foray in tropical disease was that I went to Burkina Faso, to Bobo Dioulasso, in 91, so a long time ago. And the reason I had that opportunity is that I studied in Bonn, which at that time was the capital, you know, the seat of the federal government. And one of my fellow students and friends, her dad was a real bigwig in the German Ministry for Foreign Aid. And I chatted with him on a party, and I said, you know, I really would like to do an internship, as was mentioned before. And through that, I came to Bobo, and there I was part in actually a veterinary project that looked at a disease that's very similar to sleeping sickness in cattle. And at that time, you know, I feel that I was in Africa recently, and I hadn't been for a long time, and I thought it's amazing how much closer Africa felt now than it did almost 30 years or so when I was there the first time, just because you have communication, right? So you have a cell phone. Now I could put up my cell phone and, you know, call my kids. When I was in Bobo the first time, I would write a letter that would then arrive at my girlfriend's house like 2 weeks later, and she would write back. Okay, so I was there, I came back, and maybe I learned, maybe one of the things I learned in this, that maybe I would not be the best community organizer, or not the best chief of a small hospital. And maybe, after all, I am a researcher. And I decided to find a lab that studies the biochemistry of parasites, and I did that. And then I came to the US, actually to Penn, to the biology department here at Penn, because at that time, you know, genetic manipulation strategies became available for parasites, and I wanted to learn that, and I came to the US to do that. And then for many years I had a lab at the University of Georgia in Athens, which has probably the biggest parasitology research center in the country. And I just came back to Penn recently. All right, so what we do is, as I said, I'm a molecular biologist. So essentially I make GMO parasites. Okay? So you may immediately question the wisdom of genetically manipulating parasites, but so the things that we can do are, so for example, we can take parasites and make it much easier for us to detect them. We can give them the luciferase gene from the firefly, so the firefly glows at night, so you can clone that gene, put it into this parasite, and now we can measure how many of them are there, and we can see them in mice and in other systems just by measuring light. So what we do for the last 6 years or so, the focus of my lab has been cryptosporidium. So if you look at global child mortality, about 10%, the numbers are coming down a little, but about 10% of under 5 mortality is due to diarrheal diseases. There are a large number of organisms and pathogens that can cause diarrhea, and the Gates Foundation funded a massive epi-study that followed 25,000 kids to see, okay, out of all this zoo of different viruses and bacteria and parasites, are there any standouts that would be good to focus on? And the result of those studies was that the rotavirus is the most important pathogen that was widely known, and but the big surprise was that cryptosporidium was the second most important. And I should tell you that as a scientific model, Cryptosporidium certainly was massively neglected, right? So it was very, for many technical reasons, it was very, very difficult to study, and that really held advances back. And I think many of the diseases and pathogens that DNDi supports research in are very similar. You know, we just don't have the. If you look at, okay, how many labs are there that study cancer and could develop new tools for cancer research, then those are thousands. And if you look into some of these diseases, then it's a handful or so. So this has been quite successful over the recent years. So now we have good tools. The Gates Foundation has funded a very large push to develop. So at the moment there's neither a vaccine nor drug treatment. So malnourished kids are particularly susceptible, and malnourished kids are as susceptible as HIV patients. And so Gates Foundation is funding a large push towards a drug. And so we are the most sciencey bit of that push. And I must say that for me has been really very, very interesting, because for example, to make a drug is an extremely collaborative process that requires people like the postdocs in my lab who knock out genes, chemists, social workers. You know, it's a communication, right? It's a huge endeavor, and I think an important thing is that each of these steps has to be performed at a high professional level to make the overall effort a success, right? So we can do all the research that we want. If there's no implementation in the end, then that was mute. And on the other side, you know, my clinical colleagues, if they are out somewhere with all good intentions, but they do not have a medicine to treat a patient, so they are not helped either. Okay, so maybe I'll just say a few things of how is it to be an academic scientist, and what kind of life is that? I think it's a pretty good life, right? So, you know, I think, so there's a lot of discussion at the moment, and so, oh, we're producing too many PhDs and nobody will get a job. And so, while I agree that there are difficulties, right? Well, you guys are not the first generation in this world who comes up at the time where there's difficulties, right? There's always some challenge. If I look at colleagues that grew up with me, you know, yes, indeed, it is difficult to be a full professor at a big research university. So yeah, there is some pyramid to that. But if I look at everybody else, all my colleagues and fellow students have great jobs in important fields that are not academic research, but their academic research training has been really useful to their endeavor. Okay, so what is good about science? I think science itself is good about science, and I think my feelings towards science are probably like some of you more medical people. Your feelings are towards your patients, right? So you have just an inherent love for the subject and the interaction. The other thing that I think is great about being an academic research scientist is people, right? So I have all these bright young kids in my lab at all kinds of ranges, from you know, some recent graduate that I hire as a technician to postdocs that go off and run their own labs and do more famous and important things than I myself, right? And I also think that teaching is a great component of academic research, right? If all I ever did was give, you know, I went to the Institut Pasteur in Paris for a lecture, and one of the postdocs came to me and she said, yeah, I'm here, I'm a malaria researcher, and I was an undergrad at the University of Georgia, and I liked your parasitology lecture. And I thought, well, if she develops a malaria vaccine, that was the most important thing I did in in my career, right? And so I think that comes at various levels. I was the director of a research course at the MBL in Woods Hole, and that was really inspirational to me. And there are many such interactions. You have a global set of friends and colleagues around the world, right? This is really for somebody, for a kid who came from a little blue-collar background, it was not clear to me that I would have friends in New York and Paris and London and Bobo Dioulasso, right? So that's a great opportunity. Okay, so what should you do to get a job? Okay, so first thing, you may be like me, and so I never doubted that I'm interested in science. I frequently doubted that I'm good enough at science, right? And so from that perspective, my suggestion would be, don't focus on your own anxieties about yourself so much, right? If the people around you say you are bright and young and something will happen with you, just say, okay, fine, maybe they know something about me that I don't know, trust her. And then I also like the suggestion of just approaching people. So for example, I have a lot of undergrad researchers, especially at UGA, I had a lot of undergrad researchers in my lab. And so they would write emails and I'm busy and so I wouldn't respond, right? Like many others. And, but those who wrote me 3 times and then came to my office and said, look, I wrote you many times. Could you please answer this thing? I thought, oh, this somebody with grit. I don't care what your GPA is or what you have done before. We will hire you. So, there is a lot of goodwill to you. Just take advantage of that. And then I guess the last thing is maybe I'm really interested in this bridging the gap between basic science and implementation. And I think here at Penn, one of the reasons that I came to Penn is that we would like to advance efforts towards vaccine research on this disease that we study. And I think this provides a tremendous environment to do that. But to get that to go, I think we need to work together. And the very last thing is, I agree that communication is important. So one of the most helpful things I did for the disease I study is that I wrote a rather short comment piece for Nature. And that has been really super influential, right? So something I wrote, not something I researched, and communication is really important. So at the very last thing I want to say, at the very beginning we talked about languages, and I was a really lazy high school student, and I was a lousy, so in German high schools, you get a lot of foreign language training. So I had Latin, English, and French, and I was poor at all of them. And I thought, I'm interested in biology, English. What would I do with this, right? And French. And then I went to Burkina Faso. I spent part of my dissertation in France, and then obviously I came to the SS. So to interact with other people is really important. Anything that you could do to get advice on that, I'd really encourage. Thank you so much.
Thank you so much. That was great, and again, really interesting. I was very relieved to see that nobody lifted their hand when you were asking what's more important, basic research or implementation. One of the things you learn is that global health is full of false dichotomies, like either or. It's not either or. Everything is important. HIV or primary care. Like, who says that you need to do one but not the other? It's like this mentality that we're dealing with limited resources and the best thing we can do is figure out how to distribute them. No, it's not that there's too much resources in basic science. In fact, there's too few, and that those resources are taken away from implementation. Is that we need more resources for implementation. It's not an either or. I think just really, really important point to make. So thank you very much. Thank you for attending. I think we were supposed to have like an open mic questions. But we're running a little behind, so what we're going to do, we're going to have our lunch, and we'll mingle then, and you have all the opportunity to ask questions. And then I think all of the speakers have their emails, so you should feel free to reach out to us. So thank you again for a wonderful event and for participating, and thank you to the speakers for wonderful presentations. Thank you.